relevant cognitive assessment score. If you found, or screening test, if you find some abnormality, go to the second tier, ask them to come other time, do a detailed cognitive assessment. So there are some common screening tests. I personally have done MMSE, MOCA and ACE. I never did mini-cog and GCOG, GP-cog, but these are normal basic tests. Everybody does it, but we don't know the name. But in mini-cog test, there is two parts: 3-word register, then recall, and clock drawing. If the score is 4, then it is normal. More than 2, a score less than 2 is we are dealing with some case of cognitive impairment. So in clock drawing test or GP-cog, general practitioner cognitive assessment, it has 2-part study. It's a 2-part assessment. In first, we will have a name and address recall. We will ask for the time, then clock drawing. If the scores are between 5 to 8, then better to go with the information questioning, where the informant or the patient caregiver has been asked, and if the score more than if the score is less than 6, then mostly we are dealing with cognitive impairment. Similarly, MMSE is the most common test which we are all know, but it has lot of fallacies. Basically, it doesn't has low ceiling, and it doesn't test for your executive, visuospatial, good for memory. Typical scorings are more than 24 is traditionally we consider normal, 21 to 30, 23 we consider mild, 10 to 20 moderate, less than is mostly severe. MOCA, which is the one of the best validated for MCI and best tool for cognitive assessment in a clinic. It takes less than 10 minutes. And it covers most of the domains, executive, visuospatial, as well as memory. The score is out of 30. More than 26 is normal. 18 to 25 is mild cognitive impairment. 10 to 17 is moderate. Less than 10 is severe. So it includes your visuospatial, naming, attention, language. Overall it covers most of the cognitive domains. This is a MOCA sample. So we have the trial test for executive. You have naming. You have memory recall, and as well as attention. You have serious abstractions and delayed recall. So finally, ACE3 or Edinburgh's cognitive examination. It takes usually 20 to 30 minutes to administer and should be done as a second tier test in a OPD. I won't be if you don't have time to go for a detailed cognitive assessment. It is more of a domain specific. It covers all the domains and helps you to diagnose, to give an idea, fair idea whether it is a memory, whether we are dealing with a case of Alzheimer's or whether we are dealing with a frontotemporal lobar degenerations. If the memory is low, fluency is okay, then it's mostly suggesting of Alzheimer's. If low fluency, language impairment, some kind of preserved memory, it shows FTAD. FTDs, or if you have mostly visuospatial with memory impairment, then we are dealing with some kinds of posterior cortical atrophies. CDR, it just tells the severity. It doesn't tell us the domains. So, in short, mini-cog help us to assess our memory and executive. MMMC, memory, executive and language. MOCA, orientation, memory, executive language. ACE and CDR, they cover most of them. So, MOCA and ACE, they cover most of the cognitive domains. MMSE, they cover most, but they are very they're not effective in diagnosing frontotemporal or visuospatial scores. So every scale has this blind spots, as I mentioned earlier. Mini-cog doesn't have language, complex attention. MMSE has executive function, as we discussed before. So as is. So social cognition is the test which we do. Most of the cognitive assessment scale they don't cover, and that thing we can reinforce or we can compensate by seeing the attitude of the patient or by observing the attitude of the patient. If the patient is coming from the door and we can see how the patient is behaving, that helps us to determine the social cognition. These are some frontal tests which are not included in the cognitive assessment, like your we can do the verbal fluency, your Luria test, alternating sequencing test, go-no-go test, which takes hardly 2 to 3 minutes. If you feel the patient needs frontal assessment more than the screening test, then you can go for it, as well as your occipital lobe test. So before ending my slides, I just want to tell, listening to the history, observing the attitude, and speaking with the patient plays a very important role than the cognitive assessment, because cognitive assessments may be normal or silent in patients who are highly educated or high performing adults, or who are very illiterate people. So they may overdiagnose it, or they may underdiagnose it. So always we have to correlate the cognitive assessment scale to the clinical symptoms, history and speech. So I know my faculties are all there. So they only taught me all neurology and as well as cognition. Thank you. And he is my professional mentor.
We'll be having 1 to 2 questions. Any questions? Oh, I will ask a question.
Yes, sir.
Right? We too forget a word or something in between, and within some time we recall it. I know you have written that not to be concerned about.
Yes, sir.
When are we concerned about that?
So when those things are very frequent and we are not able to recollect. For example, I'm giving an example, sir. So you have given an appointment to a patient. You are given an appointment. The patient came to your OPD, is sitting in your. The patient is sitting in the OPD, and you left. Then he will call you, or your secretary will call you and will tell, like, so this patient is waiting for you. Then you will recollect, you will remember, okay, I have given them the appointment and they are waiting. So it is retracing, you are able to recollect it. It is a normal forgetfulness. Everybody does. Okay. I do very frequently, sir. Yeah. And what is abnormal here is, if you say, no, I didn't give any appointment to anybody. I never give an appointment. Okay. And you will never able to recollect that part. So that says like you have some abnormality here. Where you are able to retrace the step. Okay, I came to this conference, I kept my bag there, I went home, then I will see my bag is not there, then I will search my bag, then I will retrace it. Okay. But if I don't realize that I left the bag somewhere, then it is abnormal, sir.
Oh, great. Because when I was presenting that we will be having a cognition conference, all our non-neurologist colleagues, we all have it, Do I have Alzheimer's? Do I need to test? That was the question.
So the similar thing is, I think when we do this cognitive, first of all, congratulations. It's a wonderful talk. I took a few pictures also to practice it, in my OPD tomorrow. But there is also a cultural perspective to it. For instance, one of the clues you said that when you ask the husband or the wife that did it happen, and she will look towards her husband. Now, I have seen that happening in normal patients also, non-cognitive patients also. Many times I ask the person, how is your appetite? Are you eating normally? And the husband looks towards the wife, or the wife looks towards the husband. Because 1 minute, culturally we are so dependent on each other, we are not individualistic like Western people, that you think. We are so much dependent, it's a web here. So a little bit of a cultural perspective also.
Yes, yes.
You wanted to say something? Okay.
Sir, culturally, I want to add one more thing, sir, which I have observed in here. So we get a lot of Somalian patients. Sir, they are wearing hijab and all those things. So there, the sense of disinhibition or socially inappropriate behavior is they are going out without wearing hijab, or sometime. Or people. So that's why I want to add, socially a social thing we can have. It's not like every time we can say disinhibition is like you're removing or undressing. It could be a simple thing like if I see an elderly person or if I see my seniors, if I greet them, it could be socially appropriate. But if I say some unwanted jokes or something which is socially inappropriate, that could be a disinhibition.
Since you brought it up, I mean, I think all of us have got similar experiences. Since you brought it up, you're very right. We also get a lot of international patients, Praveen, you know. And I am saying there is a lot of difference, even without dementia. I'm not normal. The way that they are disinhibited. Their baseline is disinhibition compared to our people. When our people come, the attendants talk, they whisper to each other. They are instinctively aware that the doctor should not be they tell each other. But those people from Somalia and all, they talk loudly. Their baseline is disinhibition. And that is normal for them. So before we diagnose FTD, we never think about it. That's from which place is he?
Thank you, Dr. Sandeep. Definitely, I was using the Minicog without knowing that I am using Minicog in day-to-day practice. We'll go to the next talk. Next talk is by Atanu sir. And to say the least, Atanu sir is the doyen of neurocognition in India. And he is a professor at Bangalore Institute of Neurosciences. And when we were going through the profile, I was wondered to see he had written the first paper from India on MCI in neurology, Green Neurology Journal, way back in 2007. And his papers all have simple questions. There were simple clinical questions, and that is pursued with rigor, and that's what we need in clinical neurology, especially in cognition. And that's why I thought sir is the best way to teach us, not only the residents, our clinicians, how to present a dementia case for examination and for day-to-day life.
One word for Atanu. He's a gentleman neurologist. Gentleman neurologist. I don't think anybody can be more gentle than him. Thanks, Atanu, for coming.
Thank you, sir. Thank you for your generous comment. And good morning, everyone. Actually, I think this audience has many of the DM residents who are going to appear in the exams in the coming days. So much of the thing has been told by Sandeep, who has very elaborately explained about the history taking and examination by a clinician. If you want to examine a patient if you want to present a patient of cognitive impairment in your exam, which most of the examiners are very fond of giving a long case, you need to concentrate on some of the basic things that in other neurology you can even ignore much of the thing in your history, but here the history is most important. And if you are getting only 45 minutes, spend at least 20 minutes on taking the history. Another 15 to 20 minutes you have to spend on examining the patient, his clinical observation of the patient. And then, of course, don't ignore the neurological examination as well. So I will begin with a case. This is a very young lady of 30 years old, educated up to 9th standard, without diabetes, hypertension. She presented with 3 years history of different types of cognitive symptom, cooking difficulty, and progressive slowness. Most of the time, the examiner prefers a case which has some demonstrable findings. So you generally do not get a patient of Alzheimer's disease in your exam, because unless you have a very classical demonstrable finding like your optic ataxia or something like that, or you can show some findings. because the examination is not only by history or analysis, it is also demonstration of the clinical findings. So here the patient has both the cognitive symptom as well as the motor symptom. She has lot of cognitive issues, misplacing objects of daily use, forgetting recent events, difficulty in naming persons or objects. So you can analyze, you can get from Sandeep's talk that they're involving multiple domains. She was cutting vegetables in an uneven manner. She also has deterioration of her cooking skill, could not manage guests. So there are problems in memory, attention, there was naming problem, there was having some judgment. Then maybe multi-step work like managing guests, and he has executive dysfunction. Could not manage daughter's daily routine, and there was some problem in simple calculation. So all spheres of cognition was affected over last 3 years. Then she also had some progressive slowness of activities, become difficult in turning, some stiffness or heaviness in limbs. There was mild tremulousness of the bilateral upper limbs at rest, slow and muffled voice. She was given levodopa for just 1.5 months, and there was not much improvement. So you got two aspects. One is the cognitive as well as the motor problem. But remember, she is 30 years old without any significant family history. If the video is working, you can see there was some bradykinesia, and also she has perioral dyskinetic movement. The facial expression was also. So, but
কোন পেনটা কাছে আছে কোন পেনটা দূরে আছে কাছের পেনটা ধরো ছেড়ে দাও কাছের পেনটা ধরো উপরে কোথায় আছো
she was having difficulty reaching to the object in place.
এবার বলো তো কোনটা কাছে আছে কোনটা দূরে আছে
So she was
আচ্ছা ছেড়ে দাও হাত নামিয়ে দাও কাছের পেনটা ধরো
what is this syndrome called?
ঠিক আছে ছেড়ে দাও
Finding is called.
বাঁ হাত দিয়ে ধরো তো কাছের পেনটাকে ছেড়ে দাও দূরের পেনটা বাঁ হাত দিয়ে ধরো
Not having a typical cerebral ataxia, but she was having a difficulty in reaching.
এবার যে পেনটা কাছে আছে সেটা বাঁ হাত দিয়ে ধরো দেখি
She was
কোন পেনটা কাছে আছে কোন পেনটা দূরে আছে
and she made quite problem in drawing the copying the drawing figures, and also she could not make a clock drawing. So what was the diagnosis? Here comes a patient who has demonstrable finding, who has cognitive dysfunction as well as motor dysfunction. So you have to make it in such a way present that all findings to be elicited and to be present in a nutshell. So history is very important. This has been emphasized time and again by different authorities. History alone provided the diagnosis in 76 to 82% of cases. So in your exam, you have to take cognitive symptom, you have to check the behavioral problems, you have to check the history of the activities of daily living. Most of the time, the instrumental activities of daily living. But you also have to take the history whether the patient has any motor symptom, a gait problem, he has swallowing problem, sphincter problem, whether there is sleep-related problem, may precede long duration, long back, because the REM sleep behavior disorder is the forerunner of many synucleinopathies. Or maybe many of the patients who have cognitive impairment might have a insomnia for long duration, maybe OSA. So concentrate on that. And seizure myoclonus in a patients who are for long duration suffering from dementia might have a seizure, but in a very subacute onset. A seizure and myoclonus suggest some of the disease which are very rare, but may find out a clue to the diagnosis and may be treatable. Elicit history from the patient as well as from the caregiver. So do not rely on the patients only, because they might be forgetting. Eliciting history is an art. So give leading questions. In India, usually the patients are not very much well versed, or maybe may not come with the history spontaneously. We have to give them clue and ask them whether these symptoms is there or not. The leading question is allowed, and you have to give leading question, otherwise you will not get the history properly. Inquire which comes first, which symptoms started first, and cognitive or motor. Might be having a motor symptom for long duration. A Parkinsonian patient might have Parkinson's disease for long duration, then 5-7 years later he might have developed this cognitive impairment. But if this starts very simultaneously, you might concentrate that it might be a patient of DLB or something, Parkinson plus. Sleep symptom, of course, I have already told. Sphincter. We always forget this, because patient might have an embarrassing symptom, but if you do not inquire this properly, they might have a urgency, might have precipitancy, and social incontinence are so embarrassing, they do not come forward. So you have to inquire them. Gait disturbance. There are maybe many type of gaits which are there in neurology, but apraxic gait. Observe the patients while walking inside the clinic, or you may ask the patient to, in examination you have to show that how the patient is walking, and you have to describe the gait. So there are many types of gait. Might have even lower motor type of gait, might have spastic gait. That you have to pick up, because cognitive impairment doesn't come alone. Behavioral symptom, all sort of checklist you have to take whether the patient has. There is several scales, but if you don't remember them, ask for the anxiety, depression. Ask for the agitation, aggression, whether there is any delusion or hallucination. Don't forget that these symptoms might be there. If you do not ask, you might miss. Sundowning, whether after the sunset or in the evening twilight, the patient is getting agitated. Then some of the behavioral symptoms which the patients usually, behavioral variant of frontotemporal dementia, they usually develop these symptoms like wandering, pacing, stereotype behavior, feeding behavior, altered sexual behavior. Then, of course, utilization behavior, echolalia, palilalia, perseverance. This you can observe while examining the patient. Activities of daily living is important. Whether the patient is qualifying for making a diagnosis of dementia, or is just having a mild cognitive impairment. I was talking about mild symptom, but without any disturbance in basic major instrumental activities of daily living. So there are a lot of things you can inquire about, and depends upon the cultural context, and also whether the patient is performing that activities routinely in her life or in his workplace. Many of the elderly persons are not allowed to go out alone or do shopping or do something banking related work. So in that case, it is very difficult to judge whether the activities are impaired or not. So that is a fallacy for assessing patients in our Indian cultural context, because we are supported. Many of the elderly persons in Indian cultural context are supported. So basic ADL and instrumental ADL. When the instrumental ADL is affected, we call them that the person is demented. But basic ADL usually remains preserved till a late stage of the dementia suffering. But ADL can also get affected because the motor dysfunction might have a very prominent Parkinsonian syndrome, or maybe might have a post-stroke spasticity or hemiparesis, or maybe a spastic quadriplegic. So that may be limiting his activities of instrumental activities of daily living. So you have to probe that, and you have to judge whether the cognitive impairment is producing the alteration of the instrumental activities. Very difficult, but sometimes you have to rely upon your judgment to look into whether the cognitive impairment is responsible for or not. And of course, a close observation is very important, whether the patient is disinhibited. I don't know if it is playing or not. The gentleman needs no, he has no.
পরেশ বাবু কেমন আছেন?
Looking into, and you can see he's also. This comes from your observation. When you ask the patient to walk, you can see there is a dystonic posturing of the left hand. So it gives you a clue that the person is having Parkinsonian gait, also asymmetric dystonia. So this might be a case of corticobasal syndrome. And if you closely observe this person is having movement of the right hand. These are myoclona. These are cortical myoclona.
এদিকে
In CVS. So might be having a few more minutes. So yes, cognitive symptom you have to judge which comes first, which most prominent symptom and the chronology of the symptom. Eliciting history of symptoms of every cognitive impairment. If the patient is coming with a just memory problem, don't take it as in our face value that it is amnestic syndrome. So you might have some other problem as well, and inquire about whether the patient has a language problem, he has navigational problem in handling finances, identifying and naming objects, initiating or completing a complex task, or multitasking problem. Forgetfulness is a universal thing. Forgetting the name of the individual may come with the forgetfulness. Forgetting the roots may be a forgetfulness. So forgetfulness doesn't mean that the patient has episodic memory problem and the patient is having Alzheimer's disease. Onset and progression. Sometimes a rapidly progressive dementia you may miss if you do not take the onset and the progression very rapidly. And rapidly progressive dementia are mostly, many of the cases are treatable. Then some of the history. Tease out the symptoms from the problem the person is facing. Problem in cooking, maybe because of multiple reasons. Maybe because of the identification of objects, collecting ingredients, cutting vegetables properly, sequencing acts, amount to be cooked. Maybe she is cooking for 2 persons, but she has cooked a lot of things. She may forget putting masalas, or she has problem in the multitask task. So it might suggest a problem in the memory, maybe executive function, may have some identification object or the semantic or the agnosias. Similarly, difficulty in shopping, maybe because of multiple reasons. So she cannot go and for shopping. The object's identification, the memory, the calculation, then of course the navigation and everything. So you have to probe what this problem is because of what. Then there are several domains of cognition, Sandeep has already told, but we divide them into cognitive phenotypes, whether the patient has primarily amnestic phenotype or the executive phenotype, or a language problem or the visual perceptual problem. And while testing, you have to have a hierarchy. Don't go to the visual spatial directly. Although the smaller cognitive assessment tools have a clock drawing test, but in our cultural setting it is very difficult. And if you do not test the attention first, if you go and test the higher level of cognitive function test, it may be difficult to judge. Primarily patient is having a lack of attention. He might have a language problem, may not be communicating with you. So primary attention need to be tested, the language function, then you can go for some other testing. There is a hierarchy for testing. Don't go to the executive function test first. Of course, I have told that examine the motor system very properly. Eye movement abnormality is very important for neurologists. dystonia, chorea, Bellism or Parkinsonism, myoclonus, spasticity, everything to be picked up. If the patient is having cognitive symptom and all these symptoms, you might give clue that the patient has basal ganglia disorder or the subcortical disorder. And some of the important things which are picked up in neurology are the levitation or alien limb phenomena, stereotyped behavior, perseveration, which you can observe, some dyskinesias, and the ICDs. ICDs are seen in patients who have Parkinson's disease for long duration with who are on particularly dopa agonist. So these are memory syndromes and dysexecutive syndrome. This is most common in examination. You will get many patients who are having subcortical dysfunctions, and most of these diseases like frontotemporal dementia, Alzheimer's, they come with other cognitive dysfunctions, but Parkinsonism, Huntington disease, vascular dementia, traumatic brain injury, demyelinating disorder and leukodystrophies, they come with dysexecutive syndrome. So you have to look into these findings to make up your diagnosis. And in these cases, the information processing speed is important, but if you ask the patient to recall something, he may not come forward, but if you give cues, he will come out. Then affective symptom, depression, apathy, and of course there is some spasticity, Parkinsonism, incontinence, all these things. So I'll stop here, and if you have any question, please. I have probably taken too much of time. Yeah? Yes, that was a young onset genetic dementia, which turned out to be a presenilin 1 mutation. It was fully worked up. We followed this patient for long duration, well, maybe 2-3 years, and she died in our hospital. Yes, sir.
So do you suggest that this MOCA assessment in OPD, do you suggest the MOCA assessment in the, beyond talking, beyond the informal interview after that, when we actually do scoring, yes, do you adjust it should be done by the doctor himself or it should be done by somebody else? What do you do in your practice? Of course, it depends upon your OPD load and all, but what is ideal?
Yes, sir. So for a neurologist who want to see the patients of dementia, he or she must be conversant with the tools and the examination. Maybe in a busy clinic, it is not always possible to do the whole MMSE or the MOCA or ACE. But if you are suspecting the cognitive impairment, you might give some more time and spend 10 minutes time to assess at least basic some amount of cognition. For quick examination of cognition, at least you can test a digit span for attention, some word list memory task for memory, a naming task, and a drawing of a clock or maybe intersecting pentagon. And if you have more time, then you can go for a detailed testing like the ACE or the MOCA. And in examination also, you have to be clear that many of the examiners, they do not prefer to know that what is the score of the MMSE or the MOCA, because you are not allowed to take a tool during your examination. So you have to divide your cognition in different aspects. What personally I think, I ask our resident also, the attention, what is the attention level? If you can say that the digit span forward is such and backward is such, so attention is impaired, that is also carries some meaning. Then for memory, you have some word list memory task. You have language, you have, at least you can test the fluency, the naming, and also some repetition. So for language function, you can have some test which you can communicate with your examination. Then visuospatial, he has difficulty in copying the figures or drawing the face of the clock. Then, of course, higher order cognitive function, the similarities, probable interpretation, you can do. So in that way, we have tested the patient. So that is what personally I think. And if the examiner allows you to take the tool with you and do the test, you can take a MOCA or ACE or something like that, and you can say that these are the scores and these are the findings. Sir, what do you say? Because you are one of the senior most examiner of the country, and you know you have taken so many exams in so many centers.
No, I agree with you. I mean, what you are telling, it's okay. If you have got time, I think it's better to be conversant. It doesn't take much time to do MOCA. I think it takes 7-8 minutes if once you have practice in it, so it's okay. No, as far as, since you are students and you have to appear in examination, make sure when you are doing this assessment that patient is himself attempting. You know, once I was examiner in AIIMS, Delhi, and for a dementia patient, I found the perfect clock. And I couldn't believe that this patient could have drawn. So naturally, I was very curious because his rest of the cognition was not consonant with that clock. So then I asked him, draw it again, and he couldn't draw it. And it turned out that his wife who was with him helped him to draw it. Because she's Jivan Sati, she'll always support him. So make sure that he's doing it himself.
Thank you. Yeah, please.
And an extension of the first speaker's talk. Is dementia assessment, is it harmful for the patient in a very busy OPD? And should dementia assessments just trigger a suspicion, but busy OPDs are probably not the right space for actually making a good diagnosis?
True, which we might sometime overdiagnose or might ignore the diagnosis or might not diagnose a patient. In previously, we used to, those who used to come to the OPD with the complaint that we are forgetting. Many of the elderly person now, they because know that the memory problem is a precursor for dementia, they come to the clinician and we used to give them assurance that this is normal aging. But nowadays we do not, because we want to pick up early. So always, if you have time, you can spend 10 minutes time, as Sir was talking about, you can make a judgment. Otherwise, keep this for future assessment, take the help of the neuropsychologist if you cannot do on your own. But to make a diagnosis, if you are making a diagnosis of dementia, of course, this is a very serious thing for the family, for the person. So you have to take time to make a diagnosis. And for that reason, you have to give time to the patient as well. And listen to the patient, to the caregiver, assess them. Then, yes, Subhana, please.
Hi. Who asked the question? Can you introduce yourselves? And you are?
Vijay Seshadri.
From?
I work at KIMS and I also work at Chetna Hospital. I'm a psychiatrist.
You're a psychiatrist. Okay, great. So actually you asked two very specific questions that when you examine a patient in the exam, is it different from the exam and in real world? I mean, first would be not at all. It's exactly the same. The purpose is to make a diagnosis. The only thing you do in an exam is you explicate your thinking process to the examiner after you have examined the patient and not necessarily in the presence of the patient. And so there is no doubt that you have to do the same, and this is for all the residents who are here. So when you see, second question you said, is it harmful for the patient? I would say that on the contrary. I think all of us, when we actually see a patient, even if it is short in the OPD or it is long in the OPD, for the patient, it is the most gratifying thing if somebody is paying attention to their cognition and is able to elicit what they cannot do, but is also demonstrate what they can do. And at the end of every examination, I think if it's like giving feedback to your colleague or to your junior or even to your friend. You start with something positive, you then you kind of find out what the impairment is, but essentially make sure by the end of the examination you have again demonstrated their strengths. And I think this form of examination is one, to make diagnosis, second, to plan rehabilitation. And for rehabilitation, you have to find out what is the impairment, but you also have to find out what is preserved. So it can, if the examination is done badly, then it is very harmful. But that is true of any real, in psychiatry, definitely. So if it is done, it has to be done well, and it can only be gratifying, both to the patient and beneficial also. We have seen in the OPD, patients are so happy after that. Those detailed neurocognitive tests where you do for research purposes, sometimes they do get tired. You have to give them breaks, and then you have to pace them, and then I think, then it is okay. But if you do it fast, push them like it's a NEET exam, that is very harmful, I think.
The challenge, what happens is, if you look at a lot of clinical practice outside, busy clinicians, you wonder whether the patient comes out, he has a diagnosis of a major cognitive disorder, or does he have a donepezil deficiency state? Okay, because the prescriptions just fly around without adequate assessment. So that's why what I was trying to
There is no
look
doubt
at,
I think that is a different
essential.
matter. Prescriptions and what we are doing as physicians, I think, is different.
Yeah.
But specifically, I think cognitive assessment is always good for the patient.
Yes.
Don't you agree, Dr. Rathi?
Yeah, of course. And sometimes I would say that diagnosis may be reserved for some patients, because in a busy clinic, or for first time who is attending the or giving this test, he may be very much apprehensive of the test score might come low. So you might have to test it again after 3 months or 6 months. Sometimes we have revised the diagnosis after repeated exam, after second examination. So it is always better to test thoroughly, and if you have doubt, re-examine this patient after 3 or 6 months. Then make a judgment and diagnosis. But diagnosis, of course, requires a whole lot of exercise. Thank you, sir. Thank you.
Now I request Dr. Navya, DM resident from Usmania Medical College, to have a case discussion.
And I thank the organizers for giving me this opportunity. I am going to present the case of a 55-year-old female who is a homemaker by occupation, right-handed and literate, who came with the chief complaints of visual disturbances since 5 years and forgetfulness since 3 years. She was apparently asymptomatic 5 years before presentation. Then she developed progressive visual disturbances, for which she initially consulted an ophthalmologist. She has changed multiple spectacles and even got bilateral cataract surgeries done, but there was no improvement. I would like to elaborate on her visual disturbances. So the difficulties in her daily life started with reading difficulty. She had the habit of reading a newspaper. She faced a difficulty such that while reading the newspaper, she used to read single words or letters, but she used to lose her place while reading the newspaper. So she used to frequently search for the previous word where she left. And she was unable to track a complete sentence. She adapted by finger tracking initially, but later that also did not work. But at this point of time, she was able to read short texts like bus boards or some labels. But later it progressed such that she was unable to even read single words and letters and even the bus boards. The second complaint is that she had difficulty identifying objects, especially when they are placed in a clutter. When she has to find a spoon from a kitchen counter, when it is left alone, she used to take it easily, but when it is among different objects, she used to search, she used to touch each of the utensil and then find out whatever she wanted. She had difficulty reaching for objects, if she had to switch on a light, she used to the attendants, it appeared as if she was looking right at the object which she wanted to reach, but she used to grope a lot with her hand before reaching it. And similar thing happened while she had to turn a doorknob. And they say that when she wants to drink tea from a teacup, she was able to take the teacup easily to her mouth, but while placing it back on the table or in the saucer, she was facing difficulty. But the movements were not clumsy. She also had difficulty with visually guided actions, like to put toothpaste on a toothbrush, she was unable to align them properly, so there was spillage of toothpaste. Also, she was unable to insert key exactly into the keyhole, and when she wanted to place utensils on the burner, she used to take the utensils slowly, carefully to the stove, but rather than placing it on the burner, she would place it adjacent to it or sometimes even on the corner of the stove, leading to fall of the utensil from the stove. She had difficulty recognizing faces, such that when familiar guests visit them, she used to talk to them as strangers until they start speaking. And she later on, she also had difficulty recognizing family members if they changed their hairstyle or if they shaved their beard. And she used to take a long time to match her sari with her blouse. And she also had difficulty identifying objects, like if she wanted to take a remote, she used to take the phone rather, but after touching it, she used to realize it is not a TV remote and place it back. And she also had difficulty with handling objects. For example, when she had to take the toothbrush, instead of holding it at the stem, she would hold it at the bristles initially and then she will guide herself. And similarly, when she's combing her hair also, she will correct after holding the comb. And she also was bumping into objects and doors and walls while walking. She has forgetfulness since the past 3 years in the form of repeating questions, forgetting conversations, misplacing her belongings, and forgetting about the medications and her meals. But her past event memory and factual memory is intact. She also has developed dressing difficulty such that she is wearing her blouse inside out, and she also has developed difficulty pleating her sari, so she is seeking assistance for the same. And she also has developed dream enactment behavior such that she vocalizes in the sleep, she acts out her dreams, and there was also history of kicking of bed partner. However, there was no hallucinations, behavioral change, autonomic symptoms, no mood or emotional change or personality change, and there was no motor, sensory or cerebellar complaints also. And she was insightful for all these complaints. Because of these symptoms, her current functional status is that she stopped cooking independently, she is unable to travel alone, she is unable to manage money, and she has become dependent for all the instrumental activities and also some basic activities of daily living. Her past history is significant for hypertension for the past 10 years. There is nothing remarkable on her personal history. Her family history showed that there are multiple members who are cognitively affected in the family in the paternal lineage. This is the patient. This is the patient, and in the paternal lineage, almost 10 people are affected so far, and showed a vertical transmission with all the generations being affected. Both male and female were affected, suggesting an autosomal dominant pattern of inheritance. And the age of onset in all of them was little younger, around 45 to 55 years of age. But the phenotypes were not the same in all the members. So one phenotype was progressive forgetfulness, wandering, personality change, and eventually these people were not able to recognize their own family members and they have become progressively dependent. This phenotype was seen in 4 patients, and one is the index case, the current case of discussion, and one member showed progressive gait impairment and personality change, and apparently he has undergone a shunt surgery, after which he had some partial improvement. And the other 4 cases of whom the details are not clearly known showed similar complaints according to the patient's attendants. So to summarize, my case is a 55-year-old female who has presented with cognitive symptoms in the form of higher order visual dysfunction and episodic memory impairment, with a past history significant for hypertension and a strong family history with an autosomal dominant pattern of inheritance. Shall I analyze the symptoms?
Yeah, you can try to be really fast.
So the first symptom is a reading difficulty, which she described. It appeared like simultaneognosia because she was unable to read the lines, though she was able to read single words and letters. But now later it has progressed to alexia, such that she was unable to read even letters. And the object identification symptom, initially she was unable to identify from a clutter. So that will also signify simultaneognosia. A dorsal stream symptom. Then difficulty reaching for objects, meaning she is unable to interpret the depth of the object, so it is visual disorientation. And difficulty with visually guided actions will be optic ataxia, so she is unable to align things properly under visual guidance. However, when it does not require vision, she is doing well. And she has difficulty recognizing familiar faces. This is prosopagnosia. And difficulty matching clothes could be color perception defect. And object misidentification could be object agnosia, and bumping into objects, again simultaneognosia. So from this, the patient has higher order visual dysfunction, both the dorsal and the ventral stream being affected. And
just a minute.
Yes.
So, an excellent presentation. So when you have, she obviously has multiple parietal visuospatial, visuoperceptual deficits. So when I think one more symptom is, did she have problems in identifying buildings? And because in the brain you have prosopagnosia, you have object agnosia, and then you have topographic agnosia.
Yes, ma'am.
And they're all very separate symptoms. Or she has a primary perceptual problem, which is like an apperceptive agnosia. So she cannot really identify anything.
Yes.
She can't identify objects, she can't identify people, she can't identify places also.
Yes, ma'am.
So do you think she has problems in general in perception, or do you think it is specific to either faces or objects?
Ma'am, initially when the symptoms started, she was able to navigate. She was able to go by herself to her doctor's appointments. So initially it was preserved, ma'am, but later on she has developed even topographical disorientation. However, within her own house, she is able to navigate.
Yeah. So when you do her examination in this patient, you have those fragmented letters, no?
Yes.
You'll be interested in looking at them.
Okay.
Say she can't identify fragmented letters,
Yes,
then it is much more basic problem in visual perception, and that can explain pretty much all her other perceptual problems. Say she can identify those fragmented letters, then you will show her pictures of famous people, objects, and all of that. So it will guide your examination later. Just show her KM80 and see she can't do it. Then that pretty much explains her visual perceptual problems. So that is how you'll narrow down which cognitive test you will focus on.
Yes.
Okay.
Then her forgetfulness is more of episodic memory impairment, which localizes to medial temporal lobe, and resting difficulty, resting apraxia localizes to right parietal lobe. So the structures affected here are predominantly the posterior cortex, occipital lobe, dorsal stream, ventral stream, and later on even the medial temporal lobes and right parietal lobe.
Yes, so far your diagnosis is correct. As Dr. Subarna was talking about that initially we thought if we want to dissect the history, whether this problem was a very global or it is very specific to identify difficulty in identifying the faces or identifying the buildings. But as per your history, there is a global deficit in the recognition and locating the objects properly. So she has a very prominent higher order visual dysfunction from the very beginning. So that might explain the agnosia part as well. The ventral stream has also got involved. So object agnosia, the prosopagnosia is a part of that. So the disease started in the occipitotemporal and occipitoparietal lobe and progressed further down the line almost 5 years history, no?
Yes.
So now it has also involved your medial temporal lobe. But the language function, apart from the alexia and her communication ability was preserved. The spoken language was preserved. So alexia, she might also have agraphia, that is posterior function. And there is no gross behavioral problem or the executive dysfunction from the history. So disease is restricted mostly on the posterior part and started there. The problem is that this is a slowly progressive degenerative disease, no problem, but and syndromically it is a posterior cortical atrophy. And we know that majority of the posterior cortical atrophy, in 80% or 90% are because of the Alzheimer's pathology. But some of them could be because of the Lewy body disease or prion or something like that. Here comes the role of this family history and the genetics. I am not very sure about which genetic mutation produces such autosomal dominant variety of dementia. Maybe some of the Alzheimer's gene might produce, but I Dr. Fahim, if you have any clue.
Oh, nice presentation, and I echo what Dr. Suvarna and Dr. Atanu sir said. I also wanted to know, you have mentioned history of RBD, right? The patient had RBD. And did the patient have any hallucinations, delusions? Because there's one more entity called PCA plus. If you have only PCA, but something beyond PCA, as Atanu sir mentioned, 80% of times you'll have AD pathology, but you can alpha-synuclein, you can have Lewy body, and you can have prion disorders as well. And as rightly mentioned, this family is an autosomal dominant pattern. And we also had some patients at NIMHAS with presenilin 1 pathology with PCA. So maybe that could be one possibility here as well. So what are your thoughts on your possibilities based on this pattern and a slowly progressive history? Now, obviously we know CJD is a rapidly progressive dementia, right? And this one is a slowly progressive one. So presenilin 1 is a likely possibility here. So I'm not sure what other possibilities, but if I have to consider one, I would consider presenilin 1 as a possibility.
Sir, though the patient has RBD, the other symptoms of DLB are not present, sir, like cognitive fluctuations or Parkinsonism, those things are absent. So, so far the likely diagnosis is atypical Alzheimer's disease only. And the family history, none of the other members showed similar complaints, sir. She is the only one who had this variant. The others had either behavioral variant or amnestic variants. So likely autosomal dominant Alzheimer's disease, so presenilin 1 being the most common one. Shall I proceed to the examination? On examination, omission and commission. However, she was oriented to time, place and person. Her MMSE is 17 and MOCA is 12. Her language assessment, apart from reading and writing difficulty, rest of the things are fine. This is how she wrote letters. This is supposed to be A. She did not finish it. And even in the second letter, we can see gross visuospatial difficulty. Then frontal lobe assessments, she was unable to do many of the tests. Probably few were contributed by her low attention also. She was unable to do set shifting, response inhibition, planning and sequencing. However, abstraction, she was able to interpret similarities and proverbs. Her insight and judgment are preserved. And her FAB score was 7/18. So few contributions by her reduced attention as well as her visual impairments. And parietal lobe functions, she was unable to draw or copy even 2D images. This is how she drew a clock. We can see the gross visuospatial difficulty in making a circle. And she has only written 1 and 2 with that too with gross visuospatial difficulty. And in left parietal, it was grossly normal except for that when asked her to pantomime transitive movements, she was using her hand initially, but she was able to correct herself. And there was also dressing apraxia. Few quick videos I'll show you. This is how she was wearing her shirt. Insinuated her hand in the wrong and she was attributing the difficulty her hand and shoulder pain. And when asked her to pantomime brushing her teeth, she was using her finger initially, but when we instructed her, she could correct. Then this is how she showed she'll comb her hair. She was using her hand. And we asked her to comb her hair using the actual comb. She was... Coming to the remote memory, her fields were intact and fundus able to describe its use or match it with a similar object. We gave her a pen actually, but when upon touching, she was immediately able to identify it. So this points towards aperceptive agnosia. Then we showed her faces. She could not match similar figures and she could not identify familiar faces. So it is aperceptive prosopagnosia. And for color identification, she was able to match similar colors when we showed her, but she was unable to point to named colors and she was unable to choose an appropriate color for an object. So this is color agnosia. Just quick videos of how she was able to. We asked her to identify a
పట్టుకొని చెప్పు ఏంటో అది.
She does not know what it is. Did she named it as a pen?
అది డోర్ వేసేది.
Identified him as her son. Broken figures I have not included, ma'am, but she was unable to identify them. Yes, ma'am. And dorsal stream also, there were gross difficulties. She had even optic ataxia. I will show few quick ones. We asked her to touch the tip of the hammer.
పట్టుకో మళ్ళీ పట్టుకో.
And when we asked her to open the bottle cap, she was able to do it. So we just inverted the bottle and asked her to do it. Then after touching the cap, she was able to hold it. And when we showed her modified cookie test, she was unable to interpret anything. And we showed her mixed figures. She was unable to identify even one figure. Rest of the examination was normal. So upon summary, there is impaired attention, executive dysfunction, episodic memory, and new learning ability. There was visual agnosia, constructional and resting apraxia, and there is simultagnosia plus optic ataxia, so partial balance syndrome.
Very, very interesting patient and very detailedly examined and demonstrated the signs. I think excellent. I think it's very reassuring that the next generation is actually top-notch presentations. So congratulations. So the only thing is when you have visual agnosia, you really have to see, is it a problem with perception, or is she perceiving properly but she can't recognize? So visual agnosia, if you can't perceive properly, and that is that fragmented letters test. So visual acuity is normal. She can count fingers at 2 feet. And say you said she's not able to do that fragmented letters. Yes. Then the question arises whether because of that all her visual functions are affected, or whether there is some amount of perceptual problem but there is also some amount of recognition problem. So that is the clinical sign here. It's like ataxia. Is it sensory ataxia or cerebellar ataxia, or is it a combination of both, or which is more prominent? So that is the only thing, but I mean it's a minor kind of a point. But otherwise I think it's very, very well presented.
So the diagnosis is posterior cortical atrophy, likely etiology Alzheimer's disease. Other conditions that can cause posterior cortical atrophy are DLB, corticobasal degeneration, and CJD, but they have been excluded from rest of the history and examination. The other key pointers are the young onset and positive family history, ma'am. This is the criteria for posterior cortical atrophy. She was satisfying 9 out of 16 criteria. So we have proceeded with CT. It was showing in the sagittal section we can appreciate gross posterior atrophy. And FDG PET scan was also showing posterior hypometabolism. So this confirms the diagnosis of posterior cortical atrophy. For positive family history, we have done genetic study and it was showing presenilin 1 mutation, autosomal dominant. So the final diagnosis is Alzheimer's disease, posterior cortical atrophy variant, familial autosomal dominant, presenilin 1 mutation. So for the management mainstay is psychoeducation, educating the family as well as the patient, and cognitive rehabilitation. These were few modifications we have advised the patient to declutter the home, improve the lighting, increase contrast, use contrasting plates, and for reading we have advised visual aids reading support. And for pharmacological management, cholinesterase inhibitor, donepezil, memantine, and for her RBD, melatonin we have advised. Thank you.
I think that was a great presentation. And a lot of people with posterior cortical atrophy now also I'm seeing being misdiagnosed in the general stream, going to ophthalmologists and wasting their time. Particularly in the beginning, they may have only, ocular ophthalmological symptoms to begin with, and the cognition may be subtle. Because you're all youngsters, the first time I heard about this term was more than 20 years ago from Dr. Suvarna, and she has diagnosed a eminent in Brain Journal. They say that if you publish in Brain, after that you can retire, but she's still around. But can you tell us that publication, which was that in Brain about posterior cortical atrophy?
I agree with we can retire. Because I think the next generation is doing such a good job. I think your teachers also have to be commended for this. So, and the first series of posterior cortical atrophy published from India is from Professor Atanu Vishwas, actually. He has a very, very nice, large series of patients with posterior cortical atrophy, and from the Indian context. And I think more recently we are actually trying to look at it, and we're looking at this cross-cultural differences, which Dr. Kaul was saying about frontal lobe disorders. We actually are less disinhibited, and Indian women are even less disinhibited, because from childhood we are told, how to behave. So we see very little disinhibition among women, and across the world now gender and disinhibition, no, that we have not, that the criteria have been made for men and not so much for women. That's also part of it. And in cross-cultural PCA, what, again, this is the work that one of the next PDF, Dr. Sahil, has done. We get that difficulty in wearing a sari very commonly, because the clothes that are wearing a sari is complicated. So you can ask that as a question, do they have problems wearing a sari? And that will immediately tell you that they have some visuospatial problems. Now regarding the presentation, basically the fact that it is Alzheimer's disease pathology, all of us now know that PCA means it's most likely Alzheimer's disease pathology. I think the first was done by one Claire Galton in Cambridge, my mentor, Professor John Hodges. He had about few patients. That's one of the first few cases. So when I went for a fellowship, and all of you should go for fellowships at your age, maybe a little later I went, and we looked at patients who were diagnosed as non-Alzheimer's disease clinically, but the pathology showed Alzheimer's disease. In that, all the PCAs had Alzheimer's disease. So that set the stage. Now, Sebastian Crutch is the leading authority on posterior cortical atrophy. You showed his, and he's very interested in collaborating with everybody. So if you have case series, you can, email him and all of that. Of course, biomarkers have changed everything in PCA. I think we'll hear from Dr. Fahim about that later. So very good presentation. Any points?
So, no, one of the, when a patient like this comes, he does not tell us that I'm having this disease. That diagnosis we have to make. And one of the differential diagnoses can be CJD in such patients. They just mimic it. I have seen in my own experience that CJD looks just like this, so you have to follow them over the course of time and do all the investigation. That's a close differential diagnosis. They can also come with these visual problems and all that thing, and little dementia.
Mohandas sir told that this patient should be presented to the faculty and their...
That such a brilliant presentation from a junior colleague speaks that probably the previous generation needs to hand over this thing to the younger one, because they are now capable of handling patients and assessing them properly.
Sir, your
congratulations.
It's always the guidance always is there.
No, I agree with everybody. Excellent presentation. I was more excited about the treatment part, because what happens in PCA, once people say it's PCA, they say now nothing can be done. But so many things can be done for PCA, especially environmental modification and what all rehabilitation you show. They can be helped with the rehabilitation. At least what will happen with rehabilitation, the progression can be slowed down and the quality of life can be made better for such patients. Because we see many PCA patients in our clinic, because they go to multiple ophthalmologists with multiple different diagnoses. And when they land with us, that time also they're in advanced state, but still at that point of time also...
10 minutes, always we are running late. And before that, we will have a felicitation for Sandeep sir and Atanu sir. I request Veena madam to please come back. Veena madam is professor of neurology at Usmania Medical College, and she is mentor for Navya and all others. Also, I had spent time with madam. Therefore, thank you, madam. I request Dr. Sandeep. Thank you, madam. We'll have a short tea break. Please, we'll assemble within 10 minutes. And we have very interesting presentations. It's the next section on biomarkers and imaging. Yeah, it is there. It's 10:15. Please assemble by 10:25.
modifying drugs than a clinician knows once they come to our clinic. I ask you, this is the reason we are all here, because we are an emerging therapeutic diagnosis and the care for to disease modifying agents also in biomarkers, because previously we had clinical definitions of all dementias, but now we have a biomarker based definition. What does that mean? Which means now you know what is the underlying pathology in the brain in vivo. Previously we used to know all this in pathologies, in CPCs, but now with the advent of biomarkers, new definitions keep on coming, and it's a dynamic field. If you see on the right side, this is a new criteria for biomarkers, where they have incorporated all the biomarkers in. A stands for amyloid, T1, T2, they're all tau. Then you have a neurodegenerative biomarker, the inflammation, then vascular, and then synuclein, and so on. So this will keep on changing depending on the new biomarker. So I'm going to keep it very simple, because fluid biomarkers for Alzheimer's disease, there are many biomarkers which are all over the place. Recently we had our colleague, he said, there are many companies who are doing biomarkers. It's not about companies. You need to see which platform, where, how they are doing these biomarkers. And the core biomarkers of Alzheimer's disease are important, which include A-beta-42, phospho-tau. I'll be telling them in my coming slides. They directly reflect the Alzheimer's disease pathology. And then there are non-specific biomarkers relevant in AD pathogenesis. They reflect neural injury, inflammation, and so on. And then there are biomarkers of common non-AD pathologies like alpha-synuclein, alphas and prion disorders and everything else. So my main focus will only be on this, the core AD pathology biomarkers. So to understand those, I think we need to know the amyloid cascade. So what I will I'll just try to map these biomarkers with the amyloid cascade. Now if you see the first step is a abnormal cleavage of this A-beta protein, right? It gets cleaved into two, A-beta-42 and A-beta-40, and A-beta-40 is produced more than A-beta-42. So the levels of A-beta-40 are quite high compared to A-beta-42. A-beta-42 is aggregation prone. It gets sequestered in oligomers and plaques. So you would have seen, maybe using biomarkers, the ratio of A-beta-40 and A-beta-42 and A-beta-40 decreases overall, and this is the first biomarker that gets elevated, and this has been approved by FDA as well. Then comes the amyloid deposition, same biomarker. After amyloid deposition, there's hyperphosphorylation of tau. And this again is a very important stage where you have important biomarkers, because phosphorylation takes place at two sites. At many sites, the most important sites are at threonine 181 and then 217. And then we have two biomarkers, phospho-tau 181, phospho-tau P217, which are elevated both in CSF as well as in blood. So this is true for both blood and CSF as well. And then subsequently you have tau pathology spread, for which you have a total tau as a biomarker, which is non-specific. And then finally you have a neural injury and cognitive impairment as well. For neural injury, you have a marker called neurofilament light chain, which is a marker for axonal degeneration and correlates with the severity of the illness. So this is the exact biomarkers that you have at this point of time. See, this is a dynamic field. They may keep on changing, but this is the core biomarkers that are available at this point of time. Now, these biomarkers are measured based on different platforms. So you have the mass spec, you have the mass spec, which is the gold standard platform, but the problem is it has a complicated data analysis, though it is high sensitivity, high specificity, but you need a high manpower and everything else, and it's expensive also. But then you have immunoassays that are low cost, high sensitivity, high specificity, and you have an easy data analysis. And these are all these platforms where you can use biomarkers. And to keep it very precise and simple, this electrochemiluminescence assay by Roche, you would have heard Roche, Fujir Bioluminescence. This one has been approved as of now by FDA, and this is for routine clinical use. Compared to others like Simoa, Nulisa, Simoa is only for research. We have been using Simoa at NIMHANS for quite a long time, and we have done a lot of research on phospho-tau ketones and 181, but this is for research. Just keep in mind, this is the only one which is FDA approved. I'll be telling about the biomarkers that they have approved for routine clinical practice. But let me come to this very important thing, why CSF is considered as a reference standard, because it directly reflects the brain pathology, because it's proximal to the CNS component, has a high diagnostic and prognostic accuracy, and it's validated in multiple large cohorts. And as I mentioned, the platforms are same, Roche and Lumipulse, and they're all FDA cleared for detecting amyloid plaques. Now again, this is a very important slide because these are the biomarkers which are approved. The ratio of A beta 40 by A beta 42, it decreases in AD and reflects the amyloid pathology. Sensitivity, specificity along more than 90%. And this is from the Fujifilm Bio, the Lumipulse G, right? And then you have phosphatide P181, A beta ratio of A beta 42. This again reflects AD pathology, and they all have high concordance with amyloid PET. Then we have total tau, which also has been seen to correlate with neurodegeneration with a high sensitivity and specificity. And these are the only CSF biomarkers approved as of now by FDA for routine clinical practical use. And out of which all of them are available right now in India as well. But you need to just remember that the cutoffs which I have shown here, they are not Indian cutoffs. They are Western cutoffs. So you need to be very cognizant of the fact when you're interpreting the results from these labs. Now, again, why we are using ratios here? Because ratios have demonstrated a high diagnostic accuracy compared to individual biomarkers, because ratios produce fewer false negative and false positive results than individual biomarkers. And these have been included in the diagnostic workup because of their high diagnostic accuracy. This is just one study where they showed higher diagnostic accuracy in CSF biomarker ratios compared to individual biomarkers. So just keep it in mind, that is the reason. And in addition, the ratios also account for many things. They account for comorbidities, they account for the total amyloid pathology as well. That's why they use ratios of biomarkers. Now, obviously, the machines cannot be kept in every hospital. You need to transfer samples, you need to store samples. These are the recommendations given by Alzheimer's Association, how to store, how to collect the sample and everything else. See, they say fasting is not required. You have to discard the first 1 or 2 ml of CSF because it reduces the blood contamination and sampling variability. And then you need to collect the required volume, 5 to 10 ml. You may collect more. But this is important. You need to collect in a specific tube which they are giving because it prevents amyloid adsorption to the plastic. A beta 42, they say, is very sticky. It gets attached to the vial. So that's why you need to be very cognizant and remember that you need to have a proper polypropylene vial. You cannot take this in any vial, whichever is available in your center. And then avoid transfers between tubes. Every transfer may decrease A beta 2 concentration. So you will get falsely negative results if their concentration varies. And then avoid visibly blood-stained CSF. Blood proteins, they interfere with biomarker quantification. Then freezing of CSF needs to be done at -20, -80 for at least 2 weeks. That does not change beta concentration, and many others. So if you want to really look into it, this is a very nice article. Please, I suggest, if somebody is interested, please go through this article. How do we transfer samples across different centers? But at the same time, CSF has its disadvantages. It's invasive. All of us know lumbar puncture limits patient acceptance and scalability. It requires specialist expertise. Procedure-related complications are there: headache, back pain, CSF leak, and really bleeding and infections. And there are pre-analytical variability, things like tube type, adsorption, handling, centrifugation, which all have a significant effect on A beta 42 concentration. Then specialized laboratories and automatic analyzers are required, less suited for primary care setting or a population level screen. You cannot do CSF in a population at the population level, right? And interpretation is still affected by mixed pathologies in a subset of cases. Now that is why we have our blood-based biomarkers, and they represent a major advance in diagnosis of Alzheimer's disease. Now, they're minimally invasive, the low cost, they're scalable, they're suitable for triage, and they're also suitable for population screening. Now, the plasma biomarkers, they have been shown to reach CSF level accuracy for both Alzheimer's and tau pathology in several cohorts. They also enable earlier identification outside the specialized centers, like in primary care. If you have to do repeated measurements, you could do it in primary care as well. You cannot do a CSF in primary care. And the best part is they can reduce the need for a amyloid PET or a CSF in up to 50 to 70% of the patients when used as a first-line test. So that is, again, very important. And as of now, only one test has been approved, blood-based biomarker for clinical use by FDA, and that is your ratio of P217 by A beta 42. And it has demonstrated a sensitivity of more than 90%, specificity, again, more than 90%. And area under curve of 0.96, and they have clearly mentioned it will serve as an adjunct to clinical evaluation rather than a standalone diagnostic test. You heard in the morning all brilliant lectures. Please, these tests are only supportive. They are not a substitute for a detailed, proper clinical history and examination. Nowadays, I've started telling my patients and my other neurology colleagues who ask me, tell us a very quick test that we can do in a busy, very busy OPD. I just tell them one thing: if you're giving such a costly drug, you need to spend some time with the patient. You cannot spend 5 minutes with the patient and give them a 50 lakh drug. So I think spending time with the patient is very important nowadays, especially counseling about the cost of the drug, the side effects, and everything else that you'll be seeing. Dr. Suvarna and Dr. Atanu will tell more about those drugs. And then the other thing about this biomarker is the levels of these biomarkers. They have created a two-approach cutoff. Now, this is one level where above this it is positive. The result is more than 0.007, it is positive. If the level is less than 0.003, it is negative. But there's an intermediate level where patients can be in this range. So you have to keep this range also in mind. And if it is in this range, then you need to go for extra investigations because you cannot play in this test. But still, blood-based biomarkers cannot be even now considered only as a standalone test to give your anti-amyloid therapies. You will have to do extra tests that I'll show in the subsequent slides. So again, there are recommendations for collecting blood as well. I showed the initial recommendations for CSF. These are the recommendations for collecting blood. Again, fasting is not required. You need an EDTA vial, 8 to 10 ml of peripheral venous blood is to be collected. And then gently in more the tube. All these guidelines are mentioned in this very nice article in more detail. So I'm not going into the detail of this. Then the Alzheimer's Association has also given one very important guideline. They say the key recommendations in this practice for using blood-based biomarkers are, if you are using it for triaging, you need to identify a blood-based biomarker which has a sensitivity of 90% and specificity of 75%. That's for triaging. But if a blood-based biomarker has a sensitivity of more than 90% and specificity again more than 90, it can serve as a substitute for amyloid imaging or CSF biomarker testing in patients with cognitive impairment presenting to a specialized memory clinic. But again, the panel cautions the users of this guideline that there's a significant variability in diagnostic test accuracy, and many commercially available blood biomarker tests do not meet the thresholds, especially using a single cutoff. That's why there's a two-approach cutoff, right? Additionally, these tests do not serve as a substitute for comprehensive clinical examination by a healthcare professional, and they should not be used only as a part of full diagnostic workup with the cognitive impairment presenting to a specialized memory clinic, and with careful consideration of pre-test probability of AD pathology. Practical implications, clinicians are encouraged to stay informed. These are all emerging paradigms, and new tests may keep on coming, and this blood biomarker field is continuing to evolve. But again, caution with blood-based biomarkers as well. There are pre-analytical challenges, collection, handling, storage. Blood concentrations are 10 to 1,000 times lower than CSF. And obviously there's a lot of peripheral noise because liver, platelets, renal clearance, comorbidity. They can all affect specificity of these biomarkers. They're influenced by age, sex, BMI, renal functions, and vascular disease. And there's cross-platform variability. Cutoffs are different across different platforms. So you need to be aware of whenever you're interpreting these tests. And as I mentioned, standalone plasma Aβ42, it is weaker than P217 and often needs multi-marker biomarker models, right? And then clinical validation is again still expanding. Still, you see different cohorts have different cutoffs. So they're trying to validate in their communities and their population groups as well. And these are one or two studies where they have seen that these blood-based biomarkers are effective in the real-world clinics with all the comorbidities, especially kidney function. But they've also seen that P217 and the ratio, they show strongest association with AD pathology despite biomarkers. After accounting for biomarkers, these are the ones who are still demonstrating diagnostic performance almost equivalent to an amyloid or a tau PET. This is one more study where they realize the same thing. They assess exact EGFR while interpreting individual biomarkers, and they observe that P217 by Aβ42 is still reliable for AD diagnosis, even in patients have comorbidities. No? Now, one size does not fit all. That is why we need our cutoffs, right? We were recently in Alzheimer's Association in London for this conference. It was a very exciting conference. But if I would not have taken my laptop plug, I would not have been able to use my laptop. So that's why we need to be aware, whatever cutoffs we are using, please question the lab. Tell them where are these cutoffs. Because when I asked them, they said it is here and there in Western people. But do we have our Indian cutoffs? Wherever we go, please go with your Indian cutoffs. Do not trust the Western cutoffs. Our cutoffs are always different. There may be mild differences, but the differences are there. Now, in EMHANS experience, we have been trying to bridge this gap, but as I mentioned, we're using Simoa. And we realized, the blood and the CSF biomarkers, they correlate well. So blood could be used as a surrogate marker for the pathology. And the levels correlate with the severity of dementia as well. And we also found the diagnostic accuracy of P217, P181 NFL, it is consistent with the global literature. And the area under curve is again more than 0.5, sensitivity, specificity is more than 90% for our biomarkers as well. And we have also tried to generate two approach cutoff for our biomarkers, right? And we are doing similar kind of a study across India to have a multicentric validation and have our Indian cutoffs for same. But again, the problem is Fugir Bio, Roche, they are the only one which are approved for routine clinical use. Simo is only approved for research. Now, you have taken a small initial step in doing amyloid scan, and now what we are trying to do is a validation using gold standard reference as amyloid and CSF biomarkers, and we are, as of now, standardizing both the CSF and the blood-based biomarkers of Fugir Bio and Roche, because these are the ones who are only approved by FDA for clinical practice, and still we do not have standard and Indian cutoffs in our population for these. And the question is why we are doing this, because we are writing an appropriate use recommendation for lecanemab, right? For that, we need to have some biomarkers with us, and they have to be validated in the Indian context. So that is the reason for doing all this groundwork. Now, this is the slide which since morning we have been discussing: clinical evaluation, comprehensive evaluation, then comes the biological diagnosis, and also important to rule out treatable causes of dementia, right? So that's why AD is not a clinical diagnosis now, it's a clinico-biological construct. So I'll go to some few interesting cases which we came across these days, because we have taken some initial baby steps while doing amyloid scans and doing the blood-based biomarkers. So case one, so this was a 60-year-old lady. She came with 2 years history of forgetfulness, independent of her daily activities of living, comorbidities, she has hypertension, diabetes, no family history, and her ACE scores were fine. HMSC was 2, KVLT was slightly on the lower side, CDR was 0.5. If you see, scan shows a mild atrophy, grade 2 hippocampal atrophy, grade 1 fazekas, and there were no microbleeds. The clinical diagnosis is mild cognitive impairment, as you heard since in the morning from Dr. Sandeep's lecture or Ratanu's lecture. This is mild cognitive impairment because patient is independent of the daily activities of living. So we did the biomarkers for this patient, and it was quite elevated. Again, we used their cutoffs because we are still trying to generate our cutoffs. With their cutoffs, it's elevated. CSF biomarkers are also elevated, and then we did the amyloid imaging is positive. I'll show this because I have one more talk on PET. So what is positive and what is negative? This is positive. So this is a case of MCI due to AD pathology. This is a very classical, straightforward case. And if this case currently comes whether in India and the Western cohorts to a clinician, they will be given anti-amyloid therapies, which is fine. But we also need to do something else that you will come to know when Dr. Sona presents a checklist for patients who have to receive anti-amyloid drugs. Coming to case 2, very interesting case again, a 67-year-old male presented with forgetfulness. He was misplacing items, repetitive questioning for last 2 years. He has some behavioral disturbance, apathy, lack of empathy for last 1.5 years. He has some wayfinding difficulty as well. And he was dependent on his daily activities of living. Father had some mild memory disturbances which were not clear as per the caregivers, and he had hypertension. And cognitive assessment showed ACE of 65, HMSC of 15, and his verbal learning was impaired. Picture naming was also impaired. CDR was 2, and his FAB was 7. If you see his scan, it is just showing grade 3 hippocampal atrophy on a coronal scan. Dorsolateral prefrontal cortex is also involved. There were no microbleeds. So our clinical diagnosis was an atypical dementia. But it could be frontal variant AD, because nowadays there's a dysexecutive variant of AD. You heard from Dr. Sandeep and Dr. Atanu sir as well. And then there's a behavioral variant of FTD. Now there's always a doubt, what is it? Now that the drugs have come, we need to know the underlying biology, right? So we did the biomarkers for this patient. It was 0.006, which is indeterminate. And the difficulty was patient was not willing for us. So despite telling them that blood biomarkers are not enough, so we need to do your CSF as well. But then we did this amyloid PET. The amyloid PET was positive. So that gave us a clue. So it is dysexecutive or a frontal variant of AD due to Alzheimer's disease pathology. So that is why the role of not only one biomarker, all the biomarkers is very important, right? So case 3, now again a very interesting case, a 74-year-old lady was referred for anti-amyloid therapy, direct for anti-amyloid therapy, because outside a diagnosis of Alzheimer's disease was made. And when she came with forgetfulness, inattention, mild episodic memory problems, difficulty in planning, organizing her daily activities. She was independent of her daily work and everything else. And she was diagnosed with hypertension. She had a TIA-like illness 1 year back. And the cognitive assessments were all okay. CDR was 0.5. 5. And again, if you see her scan, structural imaging showed some grade 2 hippocampal atrophy, some atrophy in the brain as well, and she had some grade 2 fazekas as well. And her plasma biomarkers were negative, and CSF biomarkers were also negative. Both were negative, but her amyloid PET also turned out to be negative, right? So, as I said, treatable causes have to be ruled out. Everything was negative. She was just referred for anti-amyloid, and we were also almost nearly biased that we should maybe think of somehow getting her amyloid pathology in. We did a treatable workup. GAD65 turned out to be positive. And likely possibility, this is MCI due to non-AD pathology, but there could be other possibilities as well. But this is in our routine workup, GAD turned out to be positive. And we have had a series where patients had all the atypical manifestations, and these autoantibodies turned out to be positive. On follow-ups, they became better after treatment. I know this will be questioned because they didn't have typical presentations of these autoantibodies, but still we have a series where in autoimmune dementia, patients did have atypical presentations. Right. Case 4, this is my last case. Again, a very interesting case. 59-year-old lady, she was a retired teacher, came with a gradual worsening forgetfulness, impaired recent memory, forgetting conversations and appointments, frequently misplacing objects for the last 2 years. She had progressive difficulty reading. You heard from the previous presentation. To keep the long story short, it's a case of posterior cortical atrophy. And the structural imaging showed posterior parietal atrophy, occipital atrophy. There was some medial temporal lobe atrophy as well. All features suggestive of posterior cortical atrophy. And biomarkers, blood biomarkers were negative. Now the problem here is the CSF biomarkers. If you see here, we are still, as I said, we are still trying to do. We have taken her blood-based biomarker. We are yet to analyze. But they got the CSF biomarker done from outside, and it was negative. But it was done in some Metropolis lab. And when I checked the report, I could not see which methodology they have used, where those cutoffs were generated from. It was just mentioned this was the value, and less than 0.1 is negative. It was positive, but it was 2 point. It was negative. Then we went ahead with the amyloid imaging. Now, amyloid imaging, it's positive. Why I put a doubt on it? Because there's only frontal. I'll show in my PET lecture exactly what positive and negative means. So this is a positive scan, but it is not frankly positive. It's just kind of an indeterminate thing, right? So I'll just keep it there. And the final diagnosis was PCA due to AD pathology, right? So this is what we have proposed in our recommendations for lecanemab. After careful clinical examination, cognitive assessment of patients with MCR early AD, because blood-based biomarkers are available everywhere, maybe we could use them for triaging, right? If it is positive, way above the cutoff, a shared decision-making should be done to confirm by CSF or amyloid PET, and if it is positive, AD can be ruled in, right? But then, if it is negative, AD is ruled out, you need to investigate for other causes. Then it's negative, look for treatable causes or something else. But then, if it is indeterminate, I think it's very mandatory to confirm tests either with amyloid or CSF. Ideally, both, because you see how many difficulties we're getting initially, especially in our context. Still, we are very confident, yes, this patient has Alzheimer's disease. Also, to keep in mind, you need to ensure pre-test probability of having Alzheimer's disease clinically. If you have a strong clinical suspicion that the patient has Alzheimer's disease, please then only go ahead with doing both CSF and amyloid. If you still think patient has Alzheimer's pathology, not any other pathology, right? So, lessons learned so far: biomarker should always be interpreted in the clinical context. They answer different clinical questions. Sometimes they confirm, sometimes they confuse. At times, they completely change the diagnosis. And when uncertainty remains, the question is if amyloid PET will provide a biological tiebreaker. And the biggest question is, can blood and CSF biomarkers completely replace amyloid PET? I think I'll stop there. Thank you. I'm happy to take any questions. I know it's difficult. I will not have answers.
Wonderful talk, Dr. Fine. And probably you are the best person in this country to say all this, because we do have a very limited experience of using this CSF and blood-based biomarker. But your center and Dr. Subarna and your biochemistry, neurochemistry lab, they are doing this for last quite few years, and you do have this amyloid PET where you can correlate. Yes, as you have, the last slide you have told that many things are still uncertain. We do not know. But the problem is that the labs are now offering this test, the blood-based biomarkers, and the rates are coming down drastically. So even now, some labs are doing it in 6,000 or 7,000 rupees. So it is now become easier for anyone to ask for this test and get the report. And with this report, they can go and get the drug. Although the drug is costly now. But it is now the situation is such that anyone can go and get it tested. And people are, even the non-neurologists are also asking for this test. I've seen some prescriptions from in our city. So that is the problem, sir.
I completely agree with Atanu. One of the issues with any serological tests is false positives and false negatives. Now what happens is that in other diseases, mainly demyelinating diseases and all, we do the tests. And irrespective of what they come, we treat the patient anyway. And the use we say is give the benefit of doubt to the patient. But in this case, where the
especially blood-based biomarkers. So that's why I think confirmatory tests are very important. And as you said, we can give a benefit of doubt. But I think some of our colleagues have given these drugs, right? But they have given based on blood-based biomarkers. But the blood-based biomarkers were elevated 2 to 3 times the upper limit of cutoff. I think if the pre-test probability is high and your biomarkers are quite high, they're going with your clinical correlation as well. I think that time you may consider giving it, but still talk to the patient, because it's not only about giving 30 lakh drug. See, it's all about the care of whole dementia, right? Because MRIs also have to be done subsequently, and this risk of side effects, right? ARIA and many other things, and the overall follow-up. So the cost may go beyond what is already mentioned. It's easy to say the cost is this much, but it will definitely go beyond that. It is a fancy thing. It may cost this much. You give 1+1 vial and rest will be taken care of. It may not be possible, because there are patients who are coming to us every time. One husband is daily coming to me, sir, I have to give this drug. I'm sending him back home. I'm telling him, you please discuss with everybody in the family first. Are they okay in giving this drug? Tomorrow they should not sell their house to give this drug. Because the non-pharmacological thing is also very important. For example, I think the case of PCA was presented here. We had a case of PCA with amyloid pathology, sir. And the biomarkers were quite high. As I said, this is being driven by patients nowadays. They desperately want anti-amyloid drugs. And we gave them every non-pharmacological management, but they want the drug. They don't care about the non-pharmacological part. What I'm trying to say, I think holistic care for dementia is very important. They should not think drugs are going to do something after that patient will run away. I am a firm believer of non-pharmacological management as well, because these drugs came only 1 year before, and still we have not given them. But our patients are stable. They have not worsened. I know they will worsen. But to some extent, they are stable with our non-pharmacological management. These drugs will help, but need to keep in mind, it's not a magic drug. They are only disease modifiers. They will slow the progression of the problem. That's the message I just want to give.
Does the value of these biomarkers diminish after you give the treatment, and does it indicate the lesser progression of the disease?
Yes, sir, it does. It does, because outside in all the studies wherever they have done in the West, they have done biomarker levels subsequently after giving the drugs. In fact, they have done amyloid scans. And amyloid scans have shown reduction in amyloid levels as well. So that's an indirect indicator that disease progression has been slowed down. In fact, in clinical trials, in open-label clinical trials, they have seen that the patients who receive the drugs, there's a significant gap between placebo group and the group which has received the drug, which means there is an arrest of progression or slowing of decline. But that's not the only thing we need to keep in mind. Dementia is very huge, right? So you need to have a holistic eye to see all the aspects of dementia. So it does help to some extent.
Thank you, sir. And till we have biomarkers, we rest on CT and MRI. And for the interpretation of that, we have Dr. Anantram, sir. Anantram, sir, for not only this, for each and every diagnosis, we run to him. And more often than not, he solves the puzzle. I request Anantram, sir, to present the talk about scales and patterns in dementia.
Good morning, everyone. So I go back to NIMANS where I was doing a lot of volumetries, all those things way back in 2010. So those are there as a part of our research is one thing, and the second thing is our clinical practice is something different from routine radiology reporting. So once we come back, so usually my talk this time will be just confined to the who are presenting with dementia rather than the movement disorders. And what we will think does, which is normal for age. So we consider a mild widening of the sulci, which we consider it as a normal for the age, and dilatation of the ventricles with what we see a small symmetrical cap. So a small symmetrical cap around the ventricular system, we do consider them as a normal for age. So a little bit of widening of the sulci towards the cortex, and that is one aspect what we tend to see, think it is something like age related. And then with age, we tend to see more of hypointensity, which is happening in the deep gray matter nuclei. This is one thing. And coming from imaging point of view, we have to differentiate lot of etiological causes of dementia, what it could be, whether it could be infectious, then the cortical vascular dementia, then there is any structural space occupying lesion, then there is a toxic and metabolic insults. So this entire group we have to differentiate. That will be a completely different talk. But what will be our role? So you tend to separate the neurocognitive dementias from rest of the structural dementias. That is one thing. Then we can help to monitor the progression of the disease. And as rest of the speakers are telling, we will try to now currently assess with a treatment what will be, what is the timeline and how they are progressing over a period of time. So imaging point of view, we definitely need a 3D image, mostly a 3D T1, which should be included as a part of our protocol so that we can tend to see the sulci cortex much better. So always we tend to include one 3D sequence, that is a 3D T1. So coming to the cortical atrophy scale, so as I told, will be mild atrophy is just opening of the sulci towards the cortex. Apart from the sulci, there are adjacent gyri. So what is happening to the gyri, we should tend to see whether there is a volume loss, mild, or something like a knife blade. So whenever we are seeing something like a knife blade atrophy, we are landing up in a severe atrophy that we have picked it up very late. So this is what we tend to see. Definitely we need a 3D sequence, and most of the times it is the 3D kernel, whatever it will tell us. So what we tend to see is whether there is a asymmetry is one of the most important thing. Once we have a kernel sequence, what is happening between right and left? That is what we tend to see. The sulci on the right side, they have just opened up, but the sulci, if you start seeing on the left side, they have opened up a lot, which indirectly there is a gyral atrophy also. That is one thing. And then we tend to see the hippocampus. This is one. And then there is a severe cortical atrophy, whichever is happening. Coming to the white matter, whenever we tend to describe our report, whatever we say, whenever we are trying to tell punctate foci of hyperintensities, that was grade 1. Punctate and patchy, like grade 2. And grade 3 is diffuse confluent lesions. So 1 dot per decade, we take it as a normal. So if you are seeing a 60-year-old individual with 2-3 dots here, then we tend to pass it off as a normal rather than trying to write something and then try to create something out of that report. Then these are the small punctate, these are patchy, and these are the confluent white matter hyperintensities, whatever we are seeing. So coming to the Alzheimer's, we tend to know that anteromedial aspect of the temporal lobe, there is a atrophy whichever is there. But most of the times we tend to concentrate on the hippocampus per se, rather than leaving the other two structures, what is happening to their atrophy. So we tend to see whatever the early changes are there in the entorhinal and in the perirenal cortex. And this is the collateral sulcus anterior extension, which is the rhinal sulcus. So if you start focusing on this area first, so some changes, they tend to appear first in this area, that is the transentorhinal, then they go to the limbic area. So this is the area what we are currently interested if you are trying to target a mild cognitive impairment or something else, rather than putting the pressure on the hippocampus per se. So even the medial temporal lobe atrophy scale, it starts from this way and finally it goes to the hippocampus. So this is the area we are mostly interested. What is happening to this area is the one which we tend to see. So this is what, rather than going back to the hippocampus, trying to concentrate what is happening here, this is the area we are more interested. So this is the area, whatever we are trying to see this, we think that it has Alzheimer's dementia. Definitely there will be some changes which are happening here. So this area is the one where the scaling, everything has started, and we tend to see that asymmetric pattern versus symmetric pattern. So that pattern also we have to keep in mind, and always not the hippocampal atrophy. We tend to see what are the other areas which are there before the hippocampus starts. So this, if you start seeing here, there is a significant atrophy. Then we tend to see the shape of the temporal horn. So the shape of the temporal horn also changes once there is a significant perirenal cortex atrophy. It goes up and laterally. So that is what we also tend to see what is happening. So most of the times we tend to see where there is a disproportionate atrophy. Then you tend to see here. So the atrophy, whatever which happens here, it tends to widen the choroidal fissure first. Then comes the temporal horn, then comes the hippocampus. So the medial temporal lobe atrophy scale is 1, 2, 3, 4, which starts with this one, choroidal fissure, temporal horn, and then comes to the hippocampus. So these two things happen first, and then they come to the hippocampus. So that is what we tend to see most of the times on the kernel scans. So we are interested to pick up these MCI patients rather than most of the times we tend to pick up them very advanced this thing. So this is that famous scale whatever we tend to see. So 1, it stands for widening of the choroidal fissure. So there is some volume loss which is happening here. Then 2, whatever the temporal horn. So something happens here will tend to change the temporal horn. Then comes the 3 and 4. Sorry, this is the 2. Then comes the 3 and 4. 3 and 4 are the ones which are targeting the hippocampus. So the scale also goes like this. First will be the choroidal fissure, second temporal horn, then third will be the hippocampal, moderate and a severe volume loss. So this scale has got a grading based on which we tend to see less than 75 years, more than 75 years, what is normal, what is abnormal. Then previous speakers, whatever they have spoken, the posterior cortical atrophy variant, we tend to see more of a parietal atrophy, and we tend to differentiate it from 2 other things where there is a predominantly posterior atrophy, DLB, and corticobasal degeneration, where there is an asymmetrical atrophy. So we tend to scroll T2 and FLAIR images. There is not a significant medial temporal lobe atrophy. Then as we go superiorly, we tend to see a more of a parietal lobe atrophy, whatever it is there. So why I mentioned that we need a 3D sequence, because some atrophies, they are seen better on a kernel, some are seen on axial, some are seen on a sagittal. So whatever posterior parietal lobe atrophy, we tend to see on the most of the times, if there is a 3D sequence, we are interested in widening of the 2 sulci. One is the posterior cingulate sulcus, this one, and second is the parieto-occipital sulcus. Again, the grading more or less, it remains the same. It has just opened up, gone deep with adjacent gyral atrophy, and then the gyral atrophy has become significant. So that is what. So when we have talked about Alzheimer's dementia, it is more or less a clockwise rotation which is happening from the entorhinal, perirenal, then it is coming to the hippocampus. Then there is another variant, limbic predominant age-related TDP-43 encephalopathy, which we call late, which occurs in the very elderly individuals. But this atrophy has gotten rostral to caudal pattern. So one is a clockwise, one is from superior to inferior, where there will be atrophy of the amygdala, then the head of the hippocampus, then rest of the things. And it also has got a scale which shows that this is the scale where we tend to call more or less the amygdala is an almond shaped, whatever it is there, structure. But from that it changes to a more or less a comma shaped this one. So the green one is what it tends to show here, the atrophy of the amygdala. So the same thing you can try to evaluate in the axial or also in the coronal planes. And finally, this is how the grading of the amygdala to hippocampal head, it happens from superior to inferior direction. Then coming to the other types of dementia where we tend to see there is a preferential involvement of one lobe, and also within the lobe there will be anterior to posterior distribution, and then there is an asymmetry. So these are the 3 points what we tend to see. Which lobe is getting atrophied more, within the lobe where it is there, and also whether there is a symmetric is there or asymmetrical involvement. So coming to the two usual variants, one is the frontal and the second is the language variants. So if you tend to want to assess the behavioral variant where there is a frontal sequence, two sulci. One, if you start seeing this vertical sulcus, this is the olfactory sulcus, this is one, and this the second one is the anterior cingulate sulcus. So these are the two sulci we want to evaluate in the anterior frontal lobe, and it will be in the first slice where we are trying to see the corpus callosum. So once we start seeing the corpus callosum in the first slice, then we assess these two sulci. One, the olfactory sulcus, second is the anterior cingulate sulcus, and how there is an atrophy. Again the same this thing, just widening of the sulci, gyral atrophy, again whether there is a significant gyral atrophy. Coming to the semantic variant, wherever we are trying to see is the more of the temporal lobe and also in the left temporal lobe. Again, there is a right variant also. What we tend to see, again, we go back to the kernel sequence, the first sequence where we don't see the Lyman insula, that is the junction of the frontal and the temporal lobe. Before that starts, you have to come to the first slice, and then you start trying to assess more of the lateral area, whether there is getting a significant atrophy is there or not. Again, the scale remains the same, whether it is there on the classical left side or there is an atypical on the right side. So this, if you tend to see here, there is a more atrophy on the right side. So this is what, but it is in very advanced stage where we tend to see the knife blade cortical atrophy. So this is what we tend to see. There is a mild generalized atrophy, but there is a disproportionate significant atrophy. Then coming to the language variant, where we tend to see more of a predominant left-sided atrophy and the peri-insular atrophy or perisylvian fissure. Again, where to see this one? Where kernel sequence, where we tend to see the anterior commissure. So you should see the anterior commissure in this one, and then you see the circular insular sulcus. So this is the one where the pointed one with the green arrow, this is the circular insular sulcus at the level of the anterior commissure. Then you tend to see what has happened to the sulcus which is there on the right side. It is definitely widened up and gone deep, whether on the left side it is not yet opened up. So this is what we tend to see from the imaging point of view. You need to know which slice and where to see and how to interpret it. Then coming to the dementia with Lewy bodies, again more or less, if you don't have something like a PET, most of the times, most of the MRs, they tend to have this, what we call as a non-contrast based 3D ASL sequence. So 3D ASL also will tell us actually what is happening to the perfusion. So that is an indirect way. So this patient, again the sagittal sequence where you tend to see this is the parieto-occipital sulcus, posterior cingulate sulcus, which will tell us whether there is the atrophy is there or not. So sagittal sequence will tell us more of what is happening to the posterior parietal and occipital lobe. And then we tend to see a hypoperfusion which is happening here. But this is what we tend to see. The posterior cingulate cortex is still showing a good amount of perfusion, the red arrow, what we call it as a preserved posterior cingulate island signs, cingulate island signs. So this is one thing. And from imaging point of view, what are the other things what we tend to see is in DLB is whether what we tend to see in most of the Parkinson's patient that there is a preservation of the swallowtail sign. So what we tend to see is at the level of the substantia nigra, whether there is a hyperintensity which is there in the dorsolateral aspect of the substantia nigra, whether it is there or not. So loss of this will be one of the important signs for a DLB from imaging point of view or from the MR point of view to come to some conclusion that yes, it could be a DLB. Then coming to the corticobasal degeneration, we always tend to see the asymmetry and more of a cortical volume loss which is happening around the perirolandic cortex. That is one thing. And apart from the mild volume loss in the adjacent corpus callosum. So we scroll T1, T2 axial images. We tend to go up, go up, go up. Here we are seeing a more or less a perirolandic cortical atrophy. That is one thing. And on the left side, the cortical atrophy is more significant when compared with the right side. So that is what we tend to see from the imaging point of view. The same thing you can tend to apply on the 3D ASL images also, where we tend to see more of an atrophy around the central sulcus, that is what, and ASL which shows a reduced CBF when compared with the contralateral surface. So, but most of the times what we tend to see is the vascular dementia, where we tend to see multiple cortical infarcts with an adjacent white matter changes. That is the reason I have included the white matter scale also, how we tend to report on it. So coming to the, is there anything from the MRI, and then we can go to a next level, what we can tend to see is fMRI. So fMRI is done, one is a task-based and one is the resting state fMRI. So resting state fMRI, currently we have a post-processing tool with us. So it will tell us not only the whatever the cortical structures which are there, they are not independent, they are coming as a part of one network. So it will by default, we can assess this big 5 networks. One is the default mode network, silence network, executive, and attention networks, dorsal and ventral attention. So what will happen in each case of an Alzheimer's, it is more to do with the default mode network, and it's connecting white matter tracks. So this is what a medial prefrontal, posterior cingulate, and also the inferior parietal lobule. So we can tend to see this default networks, what is happening in case of an resting state fMRI. And these are interconnected by the white matter tracks, whatever it is there. So it will be more or less the cingulate gyrus which is connecting these things. So resting state fMRI do helps us as one of the advanced imaging tools. And finally, to conclude, we tend to see whether it is generalized or lobar, and then we tend to apply the various scales, and then coming to a narrowing the differential diagnosis of the dementia. So with this, I would like to end my presentation. Yeah.
Many times we ask for MRI. MRI, there will be report as a small visual ischemic changes. And on the basis of that time, sometimes dual antiplatelets are started. Therefore, is there a way in the reporting, can we do so that that part is downplayed and patients are inadvertently not started on antiplatelets?
Sir, I agree with you, sir. As I told that if you are seeing 1 or 2 dots in an elderly individual, it is better to give it as a normal report rather than trying to write something in the impression and create a confusion. Yeah. And right from the beginning, whatever that pattern is the same, sir. If you are writing punctate means we are not that much concerned with this thing. But once we are writing that patchy and punctate in the finding, that is what a little bit of concern what we are trying to raise. And once we write the diffuse and confluent, we are definitely giving it as a higher grade, not mentioning that grades, because again, mentioning the grades in the reports and all those things, they add up some, it is just a fancy name, something you want to add in the report, but it is just writing that punctate and patchy and punctate and confluent. So this will help us to take it forward.
Almost a similar question. Many times, some people 40-year-old or 50-year-old, I mean, relatively young people, we get their MRI done for some other headaches usually. And the report comes, mild cerebral atrophy. We get very worried. I have got very worried. And age-related is okay, but I'm telling even in a 45-year-old man or 50-year-old man, it says mild cerebral atrophy. And I used to get very worried about it for obvious reasons. And then I met a director of an important institute in our country, and she told me that, you cannot look at my MRI. If you look at my MRI, you'll probably remove me as a director because my brain is grossly atrophied. So, sir, please tell us about this. I'm not talking of Alzheimer's disease or other.
Yes, sir. Yes, sir.
What is this brain atrophy?
Sir, like whatever one point you mentioned is the white matter hyperintensities. There has got a long list, like as you are trying to tell migraine patients also, we see so many non-specific white matter hyperintensities. But somebody wants to add that in the report, it is better to describe it as a non-specific white matter hyperintensities in the impression, rather than I'm seeing a white dot, it might be normal for age, I don't want to include in the report gaps which are there around the ventricular system. They should be passed off as a normal. So whenever we are writing an impression from radiology people point of view also, we should think that what the next implication will be there, rather than trying to over-report. Sometimes we should try to stop. If we do a 3D sequence, and that sequence, if it is properly interpreted, will give us some clue, rather than we are trying to focus everything on the hippocampus, then our perception of that imaging interpretation will change. There are some other structures. Always we tend to see right versus left asymmetry, whether it is there or not, and there is a disproportionate. So these are the 2 points. If you tend to see any area where there is a disproportionate atrophy and there is asymmetry, better to make a note of it and then leave it to the clinician. That will be the right points.
Thank you for a really excellent talk. I think it was very useful for all of us to see at which slice to look for atrophy. My question is, we are clinicians, so we see patients and we formulate a clinical diagnosis, maybe semantic dementia, right temporal variant, and we directly look for that area. And then we find atrophy there. But if you were to agnostically look at the MRI, you will see other areas of the brain also atrophied. So how important do you think this differential atrophy is to make, do you use this differential atrophy to guide you in making a imaging diagnosis?
Yes, madam. Whatever the differential atrophy is from imaging point of view, that is one of the clue. And as you have told in my presentation, if you are looking at a wrong slice, we'll make a wrong diagnosis. But if you look at the correct slice, like kernel, if you are asking for a dementia, means a 3D sequence should be there. Then we will reconstruct it into axial, sagittal, and kernel, and then that will play us. But if you are asking us to dementia with a routine stroke brain protocol, even I may not be able to pick up that subtle atrophy, because these are routine imaging is 4 to 5 mm thickness. Those are 1 mm and sub-millimeter sections will tell us a different story.
Excellent presentation, Dr. Ram. I just wanted to ask, see, sometimes we have clinico-radiological discordance. Clinically we see something, but radiologically we see something else. Because what happens in our hospital as well, clinically you would have diagnosed something, radiologically they would have reported something else. It happens many times. So do you think we'll reach a stage where we'll be able to establish connectivity patterns, not on research, just individually, the way we are seeing atrophy, can we see connectivity between one part of the brain to the other? We are using like DTI, seeing white matter tracks and everything. Is it possible to do that clinically? On a research, we know many things are happening, but is it possible? See, PET and other things are fine, but do we have anything is it coming up in future or so, the connectivity patterns we could see individual case-by-case basis?
Sir, that is what, sir. Whatever we have taken up that resting state fMRI, whatever it is, that was a part of the surgical armamentarium where we wanted to see the resting state fMRI, because all these days we were doing only task-based. So we never went ahead and did the resting state fMRI. That is one thing. And second thing, to answer that, now so many softwares also have come up where do this some amount of quantification. Like we have a routine Philips ISP called post-processing software, which we have taken for entire head to toe, but it has got its quantification software. So these quantification softwares is one which will tell us about the cortex, but the second way to pick it up is only by the resting state fMRI, because as you told, that cortex are all part of ultimately one network. So wherever we are seeing the cortical atrophy, they are part of one network. If you want to assess by task-based, you just assess only that area, but you don't assess the entire network. So I think that resting state fMRI softwares, which even Indian-based, they have cut down the price significantly. Those and quantification, these things will take us forwards.
Thank you.
Yep. Thank you, Anantram sir. I would request Kaul sir to give a memento to Anantram sir. He would be leaving. हाँ फोटो है सर.
Thank you, sir.
Thank you, Anantram sir. Now from MRI we will jump back to another talk by Fahim Arshad sir, and we'll talk about PET scan in the neurodegenerative. We hardly see, we don't have it anywhere in India till now, except in NIMHANS. Therefore, we'll learn definitely from the talk.
Yeah, thank you very much for giving me a second talk. I just have a disclosure that I am not a radiologist and I am not a nuclear medicine specialist as well, but it's nice to talk on PET because we are doing it here, and we're having some interesting findings, because I have used PET for around, FDG PET for last, I think, more than 5 years, but amyloid PET we have started using recently, as I showed in my previous talk. So basically I spoke about biomarkers, fluid biomarkers. Now this is an imaging biomarker that we have right now. So it could be structural imaging, which Dr. Ram showed. He has made my job easy, so I don't have to talk much about structural imaging. And then we have molecular imaging, and then we have metabolic imaging. And there are other emerging modalities that are also there. And as far as the metabolic imaging is concerned, you have FDG PET, and then for molecular imaging, you have tau PET, and you have an amyloid PET, right? They tell about the molecular biology, what is happening in the brain. Now, coming to the overall PET, is a non-invasive imaging technique that visualizes the physiological, metabolic, and molecular processes in the brain. And the basic principle being a radio tracer, which is labeled with a positron-emitting isotope. It could be F18 or C11, and it is administered IV, and the tracer accumulates in the tissues, emits positron, which annihilate with an electron. Interaction happens, it produces a photon, and the scanner detects and reconstructs a three-dimensional image, and we see that representations of tracer distribution across the brain. Now, why it is important? Because it provides functional and molecular information in the brain, detects the disease before structural changes appear, and it enables early diagnosis and helps in differential diagnosis, and supports precision medicine by identifying specific pathological processes. Now, these are different types of PETs that are available that I showed in my initial image, but I will only focus on this part, the FDG PET, amyloid PET, and maybe some things about the tau PET, because we have started doing these as well. Now, coming to FDG PET, it's one of the most commonly used marker of early neurodegeneration, and the tracer that we use is fluorodeoxyglucose. It's again a glucose analog. It's transported in the brain via glucose transporters. And the brain metabolism is glucose dependent. The mapping of brain glucose metabolism generally is a reflection of neuronal synaptic activity. And overall, this sensitively detects the altered neural connectivity in the brain, and this is associated with neurodegeneration. And it's used extensively in research, both for dementia and for other movement disorders as well. Now, each degenerative dementia subtype has a unique pattern. They depict early metabolic changes with all the neurodegenerative disorders before structural changes on CT or MRI, and this allows early diagnosis and prediction of further cognitive decline. Now, indications of PET, as I mentioned, early detection of neurodegeneration, patients having rapidly progressive forms of cognitive impairment, especially young patients less than 45 years of age. Cases in which combination of clinical, neuropsychological, and structural imaging assessment does not allow us to establish a diagnosis, like an atypical dementia. For them also FDG PET is quite useful. And with overlapping symptoms between different degenerative disorders, it can help us clarify diagnosis by revealing some distinct metabolic patterns, making it a crucial diagnostic biomarker. And this is a normal FDG PET. Well, it's difficult to define normal. Sometimes normal is normal if there's no regional or any hypermetabolism any side of the brain. It's a uniformly metabolic state, so it's normal, right? Coming to amyloid PET, it's again a molecular imaging technique that enables in vivo visualization of fibrillary beta amyloid plaque. This is one of the amyloid in the amyloid cascade, one of the pathological hallmarks of Alzheimer's disease, and it directly identifies amyloid pathology, allowing confirmation of Alzheimer's disease pathology during life. And the images are interpreted in two ways. One is a visual read. It could be positive, showing an abnormal cortical uptake, or it could be negative with absence of cortical uptake. And there's another way of quantifying it using centiloid scale from a score of 0 to 100. And there are cutoffs for this as well. And overall, the clinical importance, as I mentioned, it will detect amyloid in the brain at least 10 to 20 years before the dementia onset. It will support an early and accurate diagnosis. It improves our diagnostic confidence in atypical presentations, as I showed in my previous presentation. And it's an essential biomarker nowadays for anti-amyloid therapies. Because the drugs have come, we need a biomarker confirmation for giving these drugs. And it has also been incorporated in the latest ATN criteria for Alzheimer's disease. And these are the various tracers that are being used. And if you see, the first three tracers are the only ones which are FDA approved. And, we are using at NIMHANS, which is called the NAV, the last one, NAV 4694, because the first three ones, they are not available in India due to some logistic reasons, but we have used NAV for all our patients in the last 2-3 months, and this is again based on research itself. And every PET has a different pattern. Every amyloid PET using different tracers have a different pattern of positive or a negative read. But overall, the basics remain the same. So if you see on the left side, these are all negative ones, the right side are positive ones. But don't go into it. I'll just simplify with this one that we have been using at NIMHANS. Now, if you see the first one, you see the red one, this is all white matter uptake. Basically, white matter has a lot of myelin. And all these tracers, they have non-specific affinity for myelin, right? So once you give it a normal patient, it's a negative scan, it will get, the uptake will be there only in the white matter, not in the cortical areas. Now, if you see this case, this is a positive scan for patient with Alzheimer's disease, there's a loss of gray-white matter differentiation. In a negative scan, you see the gray-white matter differentiation is preserved. I think that is the basic difference. This is true for almost all the amyloid, the tracers, except for few, but we are not going to go into those. But the basics remain the same. That is the basic difference between. If you see full cortical uptake in this positive scan, that is the main difference in this. And same when for tau PET. This enables in vivo visualization and quantification of tau neurofibrillary tangles in the brain. Again, it uses a radiolabeled tracer that binds to the pathological tau, allowing distribution and burden of tau pathology with this PET imaging. Now, this follows a stereotype pattern, which is called the Braak staging, which begins in the medial temporal lobe and progressively involves the neocortical regions. In the amyloid scan, in the amyloid PET, this is a reverse pattern. You have first neocortical involvement, and then finally it goes to the medial temporal lobes. Now, unlike amyloid scan, tau burden relates with the cognitive decline and clinical disease severity, making it a very important marker of disease progression. Now, what is the significance? Now, it detects and tau pathology and stages tau pathology into low burden, high burden, initial stage, late stage. It also improves diagnostic confidence, particularly in atypical AD presentations. Helps distinguish Alzheimer's from non-Alzheimer's neurodegenerative pathology, and obviously complements all other biomarkers and amyloid imaging as well. Now, these are different tau tracers. Now, we have fluortaucipir. This is approved, and this is available in India, and we have been using it, not using it very frequently. We just use it for one patient. I will show that one scan. And there are others also which are being used worldwide. But the fluortaucipir is something which is very standard, and it has been used worldwide as a tracer scan. Now, this is a tau PET scan. You see at the top, this is the normal scan, and below you see this is the uptake Wherever you see this green, this is the uptake. But at the basal ganglia, this is called the off-label binding. They say it is normal. But this all is an uptake, which means the tau is present in the brain. This is a positive scan. For tau, again, you have two ways. You have visual read scan, or you can do quantification using your centralized scales, or they call it the SUVR values. Now I'll just go to the some cases. It's more of I put up more of a case-based discussion. I'll try to finish in another 5 or 10 minutes. I'll try to show as many cases as possible. I'll not go into the details of history again. This is again a patient of mild cognitive impairment with all the history. And if you see, the scan is almost normal, maybe grade 1 to 2 medial temporal lobe atrophy. Again, they report this as a gross cerebral atrophy kind of a thing. So this is very important if you start doing a PET scan in this patient. Now if you see, there is hypometabolism in the brain, bilateral, temporal, and this patient had posterior cingulate atrophy as well. And the precuneus is also to some extent involved. So this is a hypometabolism in a patient with MCI. And this has predictive value. If a patient with MCI comes with a hypometabolic pattern in the PET, there are chances that this patient will progress to AD. Compared to a patient who is MCI with a normal pattern, normal metabolic pattern FDG PET, they have less chances of progressing to AD. That is one thing which is important to know. And this patient, we got a amyloid PET scan done. This is positive. You can see there's loss of gray-white matter differentiation, not that much, but still there's a lot of cortical uptake in this patient. And then this patient had a positive biomarker as well. So the final diagnosis was MCI due to AD pathology. Now this is again one patient with again Alzheimer's disease, presenilin 2 mutation with all the history and everything else. Here bilateral medial temporal lobe atrophy. Initially there were diagnostic dilemmas. Maybe it is Alzheimer's disease. It is frontotemporal dementia as well. But then this patient had bilateral parietal hypometabolism, posterior cingulate was also involved. So overall, again, this was suggestive of Alzheimer's disease pathology because we got this patient's PET amyloid scan done as well. And again, if you see there's loss of gray-white matter differentiation, and there is a cortical uptake in this patient as well. The final diagnosis was Alzheimer's disease due to AD pathology. The biomarkers are still pending for this patient, right? And then same way, a patient with language disorders, objects, word finding difficulty, impaired repetition, difficulty in complex comprehension, and word finding difficulty, inability to navigate familiar and unfamiliar routes. And this patient also had difficulty in expressing themselves. There wasn't frank agrammatism, but there was a doubt whether is this a logopenic variant or this is a primary progressive non-fluent aphasia. Then we got this scan done. Again, if you see, there is atrophy in the left front temporoparietal area, and we got an FDG PET done for this patient. Now see the pattern here. There's a symmetric left temporoparietal atrophy on the right side as well, but predominantly on the left side. And we got this patient's biomarker done and an amyloid scan done. Again, if you see, the cortical uptake is there, and the biomarkers were also positive. So this was a case of logopenic variant PPA secondary to AD pathology. Now coming to one more case, again, we have been discussing since morning posterior cortical atrophy. Again, a patient with classical symptoms of posterior cortical atrophy. Just to show this case, because sometimes you may not have classical symptoms initially, but you will have this posterior parietal atrophy like this, and you may have mild medial temporal lobe atrophy as well. And then when you do their FDG PET, you'll find all these patterns. Temporoparietal atrophy, posterior cingulate may also be involved, and then there is mild uptake in amyloid PET scan as well. It may not be a classical or a frank amyloid uptake, but there is an amyloid uptake with patients' biomarker levels are also positive. Basically, for such scans, we need centroid values. We need to quantify the exact amyloid levels, and also it depends on the areas involved. For Alzheimer's disease overall, it's a posterior cingulate and the precuneus and the lateral temporoparietal areas that are involved and to be seen when we are interpreting a visual read scan of an amyloid PET. Again, a patient came with atypical AD, a 65-year-old gentleman, and had difficulty planning, organizing, looked like a dysexecutive variant, but we were not sure. And if you see the scan here, there's a dorsolateral prefrontal cortex atrophy. Again, medial temporal lobes are also involved. You can see this part, and you can see the medial temporal lobes were also involved. And this the PET pattern, again, hypometabolism, bilateral dorsolateral prefrontal cortex, and temporal lobes are also involved. Posterior cingulate was also hypometabolic in this patient, and the amyloid scan was again positive. Again, as I mentioned, visual read is positive, but pending quantification and the biomarker levels of this patient. So again, this is the case of an atypical dysexecutive variant of AD. Now, this was a very interesting case. 64-year-old man, he was again referred as Alzheimer's and with anti-amyloid drugs being given. Sleep disturbances for last 3 years, forgetfulness 2 years, slowness of ADLs 1 year, tremulousness 1 year, and apathy. And cognitive assessment scores were quite slightly reduced. ACE was around 81, HMSC was 24, CDR was 0.5. And then his scan was done outside, which was not suggestive of Alzheimer's disease. If you see, this is again not much atrophy, very mild. It could be even reported as mild cerebral atrophy. And the scan, positive, negative? Negative, excellent. It's a negative scan, right? And this patient came to us, but then we reviewed this patient history again. This history didn't come up initially. It came up later on. The patient had behavioral disturbances, auditory hallucinations, delusions, apathy. Later on, visual hallucinations as well. So this was not missed because patients didn't come up with this history. As you heard from Atanu sir, you have to go back into the history, ask the history if it is there. Right? And then we got this patient's PET scan done. As Dr. Ram mentioned, this patient had posterior cingulate sign, and there was hypometabolism in the occipital area, and the posterior cingulate area was well preserved. So this was a likely possible to probable case of a DLBD. It could even be FTD because I realized there is anterior cingulate hypometabolism as well. But then we treated this patient with rivastigmine because with rivastigmine these patients respond like anything. And same thing happened with this patient. They recently came back and he has slightly become better. At least the visual hallucinations had become better. If at all he would have been FTD, maybe he would have worsened further. But he was quite okay. That gave me a reassurance that likely we are on a proper channel. This was a case of classical FTD, as I think Dr. Ram already showed in one of his slides. And you can see bilateral atrophy, cingulate atrophy, dorsolateral prefrontal atrophy, and there was some medial temporal lobe atrophy as well. And this is a classical case of a behavioral variant FTD, just to show hypometabolism in the frontal lobes, anterior cingulate, dorsolateral prefrontal cortex, and the posterior part was at least preserved. Another case, a semantic variant, primary progressive aphasia. I think Dr. Ram showed this case as well. And again, sometimes what happens, we have mixed PPAs. So that time FDG PET is going to help us. Is it a logopenic variant? Is it a semantic? Semantic variants are very classic. There's no confusion about them. But sometimes logopenic and primary progressive non-fluent aphasia, there is a doubt sometimes. But this was a classical case of a semantic variant, just to show preserved posterior cingulate metabolism and anterior cingulate hypometabolism in this patient. Right? Now, some very peculiar cases. This is a rapidly progressive cognitive decline patient, 45-year-old, 6 months history of progressive cognitive decline, difficulty managing finances, repetitive questioning, fluctuating cognition, confusion, behavioral changes with apathy, irritability, emotional ability, and intermittent visual hallucinations. He was paranoid. He had some seizures as well, disturbed sleep, all very vague symptoms. His A score was 63. And any idea about the clinical diagnosis? Correct. CJD, somebody said. Anybody else? So we got his scan done. There is again medial temporal atrophy, and his diffusion was clear. There was no evidence of any CJD in this patient. His CSF was strongly positive for NMDA, both serum and CSF. EEG just showed some generalized slowing. And this is on case of an autoimmune dementia. You see 6 months history only. This is hypermetabolic pattern, classical of autoimmune encephalitis or autoimmune dementia. You can see, I showed you all the previous hypometabolic scans, or maybe novel metabolism. This, you see, everything is firing off. So this is a classical case of a patient who has autoimmune encephalitis. Rapidly progressive dementia, again, 1 year history, visuospatial, visual perceptual disturbances, dressing apraxia, alexia, word finding difficulty. There was a family history of AD and Parkinson's disease in siblings. An examination showed Parkinsonism, cerebellar signs, myoclonus, and his ACE was around 47. Now, this is a classical case of CJD, and this is an extremely hypometabolic brain. This patient came, in fact, their caregivers came recently. I thought just to show this scan at least, to see what kind of a brain patients with CJD have as far as the PET, FDG PET is concerned. My last case, a very important case, interesting too. 49-year-old lady comes with 1.5 years progressive memory impairment. Classical amnestic MCA. She had a family history of dementia, mother was affected. We did all our workup as we do for all treatable causes. Our NMDA was positive. We treated her as a treatable cause of cognitive decline. We treated her with methylprednisolone for 6 months. We also gave plasmapheresis. She stabilized, But after 6 to 8 months, he's further worsened, particularly in her episodic memory. So because the husband came and he wanted us to reevaluate her, we did some reevaluation. She was quite normal. We didn't have a PET scan that time. This is just last 2 months story. And we thought, let's do a PET scan. Maybe she has a family history of dementia as well, whether she has Alzheimer's. So we got her amyloid PET done, which was positive. Got the biomarkers done, biomarkers, serum, CSF, they were cooperative for everything. And finally, we also did their PET scan. And if you see, the PET scan is positive as well. There's a posterior cingulate uptake, there's a posterior bilateral parietal uptake as well. So this is a positive tau scan, a positive amyloid scan as well. And this patient had a diagnosis of Alzheimer's disease, secondary to obviously AD pathology, and tau was also positive. So this is my last slide. FDG PET provides metabolic signatures that facilitate early diagnosis, differential diagnosis across major dementia syndromes. And amyloid scan definitely has transformed the AD diagnosis by enabling in vivo detection of this amyloid pathology, improving our diagnostic confidence, and obviously guiding disease-modifying therapies and reducing the diagnostic uncertainty. And tau PET, an imaging correlate of neurodegeneration and clinical severity, reflects the later stages of the disease more accurately than the amyloid stage. Now, together, all these, they provide a complementary rather than a competing information. For future dementia diagnosis definitely lies in a multimodal approach, a multimodal biomarker approach, integrating clinical evaluation. Please don't forget clinical evaluation, because that's very important. You need to correlate these things clinically as well, and then involve your fluid biomarkers and your PET imaging to enable more earlier, accurate, and biologically defined diagnosis, supporting the precision medicine. Thank you.
Thank you, Fahim. So this amyloid PET, what does that cortical hyperintensity in the FDG PET actually, not in the FDG, sorry, in the amyloid PET represent? Is it actually amyloid there which looks as red, or is it interruption of blood-brain barrier? And what does it, in the white matter it's red. What does that white matter red? So what actually redness means? In the cortex as well as in the white matter?
So that's a great question, sir. So in the white matter, basically there's a lot of myelin in the white matter. And these tracers, they have high affinity for myelin. So they, whenever these tracers are given, they get all accumulated in the myelin. As far as the positive scans are concerned, this is actually the amyloid. This is the cortical amyloid in the brain, which is being shown by these tracers. So basically, that's why we say the loss of gray-white matter differentiation, which is very important. If you have only white matter uptake, that is not your amyloid. White matter doesn't have amyloid. It's the myelin, non-specific myelin, and these tracers have a lot of affinity for them. That's why it captures those. As far as the cortex is concerned, it's the actual amyloid which it picks up.
Sir, I wanted to ask about autoimmune encephalitis, FDG PET. The diagnostic criteria, it's not there. But we commonly use it because many of the antibodies are negative, and sometimes if the clinical and the radiological or FDG PET goes in favor, we start treatment also. How do you see this scenario evolving? Will it be ultimately included in the diagnostic criteria?
Well, I'm not an expert in putting that in a diagnostic criteria, but I think it should. See, at the end of the day, it depends on the clinician, right? With what you are suspecting and what you think about that patient after correlating everything clinically. I think they should be included, but see, every patient, we have seen so many autoimmune dementias, all don't have this typical classical pattern of hypermetabolism. We have majority of the time seen hypometabolic patterns only, because those patients had a progressive illness for maybe 1 year, 2 years, and the autoantibodies were positive in those patients, but we treated them. And they became better to some extent because we have a follow-up of all those cases. So you're right. I think they should be mentioned in the criteria somehow. If not definitive, they should be there as a supportive criteria. And some people do believe in it, and some people still are questioning those criteria. Thank you.
So we should, what Praveen is telling about the autoimmune encephalitis suspected with hypo, which you would expect. But at least you need antibodies, something you need. But if everything is negative, then we should not treat for the benefit of doubt.
Exactly, sir. Because I know many of our colleagues treat seronegative autoimmune. I am not a believer of seronegative because if somebody is not there, if I am not there, you cannot say seronegative for him, right? So, so I am not a firm believer of seronegative autoimmune encephalitis. There has to be some evidence because if I showed you this last patient NMDA was there. It was 1+. It was not 2+. Because, but at the same time, I think in my emergency casualty, I was suddenly called one day, sir, this patient has bilateral temporal lobe hyperintensity, insula is also involved, serum antibody is negative, CSF is negative, but it still looks like a autoimmune encephalitis. Then, as I'm not a believer of, but somehow I treated this patient with steroids and plasmapheresis, and she became completely better. I mean, it depends. Because the other thing is we don't do all antibodies, sir. We are missing some antibodies. There's a full spectrum of antibodies nowadays. Maybe we have other antibodies also which we do not know about, right? So that is one more. Because we are doing just one set of 4 or 5 antibodies. There could be other antibodies which may be coming into play.
It's a wonderful talk, Fahim, once again. And the issue which you have highlighted is that no investigation to be interpreted without the clinical context. That is more important. And it is the clinician who should know how to read the MRI and this sophisticated test. Because otherwise, if you are not capable of reading the MRI, sir, this is true for all others also, demyelination and also for the stroke neurologist, they should read their own MRI. It is not, the neurologist should learn reading their MRI and also these scans. Otherwise, it will be fruitless. Only the report cannot make a diagnosis. That is what my concern.
Sir, just to add, and it has implications because we have seen many FDG PETs because we see patients in clinics and we correlate them with FDG PET. But when we see the report is reported something else. So I think that's why a clinician has to see a patient in a holistic way.
Yeah, Praveen, same question. We have often discussed about it, this PET thing, this PET imbroglio, how it confuses. So I have asked many foreign people, and they say they don't need a PET for autoimmune encephalitis. They just do clinical MRI and antibodies. And Ratnavali, who is not here, in one of the webinars recently I saw, she said she has stopped doing PET for dementia, for everything, because of the interpretation problems. Because of the interpretation problems that, how people report them.
Yes. Yep. Thank you, sir. It was wonderful talk, both of them. Yep. Now we have discussions about biomarkers and all. Now we want to diagnose Alzheimer's, but there is a big differential is that, and in that I request Suvarna madam, our teacher, our mentor, to talk about it. Madam needs no introduction. Madam has been the pioneer to set up. When we were the PGs, we had the memory clinic at KIMS, and I was fortunate to be with Madam. And Madam is a global figure in cognitive neurology. And with big enthusiasm, I read about the bilingualism and cognitive reserve. That was a wonderful thought, and because I myself know about 4 languages, therefore I thought I would have a better cognitive reserve. Thank you, madam, and please present.
Thank you, Praveen, and very good morning. And first of all, I'd like to congratulate Praveen for putting together a fantastic program. I think that this is probably the first time in India that such detailed discussions we are having about differential diagnosis of dementia, putting together state-of-art methods. And also, Hyderabad has been the place which actually started looking at differential diagnosis of dementia carefully. We have Sirisha here. So we are talking about PET, but I remember when we were developing the Edinburgh's cognitive examination, when the patient could not, cow patient that Dr. Sandeep was talking about, where all animals were cow, she came to me and she said, Madam, I think this patient has a semantic dementia. So we have youngsters here who have taken the challenge of diagnosing dementia properly, and it's only fitting that this latest kid on the block, that is these PET and biomarkers, are helping us to diagnose. So since morning we have heard about how to approach a patient with dementia. I think in this talk, I'll just be summarizing what everybody has said. I don't think I have one slide also which has not already been touched upon. So it will be a very quick review. The exciting thing for dementia is that we have reached where stroke and multiple sclerosis and epilepsy are. It's clinical evaluation, it's imaging, it's biomarkers, it is multimodal imaging, it's caregivers' opinion, and then again coming back to the history to make a diagnosis. So dementia is on the threshold of a lot of excitement. You've also heard from Dr. Fahim about how we approach dementia and enhance in the OPD. He actually has just given the talk. All the 9 cases he showed were all in the last 2 months or 3 months. So our OPDs, when we make a diagnosis, are like this. We have so many things that we have to look into: the history, revise the history, go back and ask the history. Then we have biomarkers, and then you have blood, CSF, amyloid biomarkers. There's concordance sometimes, there is discordance sometimes. And then there's so many treatable causes of dementia. We should not miss that oral ulcer to pick up inflammatory cause of cognitive impairment. So it's challenging, but it's also very necessary. And I'm sure that all of you will take this forward. I have no doubt at all. And I will just very quickly run through the slides. Most of it has been covered already, and I'm very happy to say that it'll just be a revision. So in the OPD, we heard from the first 2 talks about how you make a diagnosis of dementia. So for Alzheimer's disease, typically it is memory loss. They tell you that he has forgotten what he knew. He has forgotten what he has experienced. So that is amnestic Alzheimer's disease. So you have experienced something, you have gone on a holiday, or you have spoken to somebody, or somebody has. That is classical Alzheimer's disease. And there is no doubt about that. It is episodic memory impairment. And then you have medial temporal atrophy. So this is when in the OPD we always say this is classical Alzheimer's disease, an older person. And then when you do the tests, you have given him some words, and then you have told it 3-4 times, and then after some time, he can't remember the words. This is Alzheimer's disease. And why does this happen? Because amyloid and tau accumulate in the brain slowly, but typically tau accumulates in the medial temporal lobe. And then gradually it spreads to the rest of the brain. And that is why there is memory loss. So there is a good clinical and pathological correlation for classical Alzheimer's disease. So in the OPD, you can say, okay, this is probably amyloid and tau. And then this was so many years back, I think 25 years back, that we looked at all these, the brain paper that Dr. Kaul was saying. We looked at people who come to the OPD without classical memory symptoms. They come with either progress does not look like Alzheimer's disease, and then when they looked at the pathology, it was Alzheimer's disease. So then the correct diagnosis of Alzheimer's disease was only possible on pathology. So all these patients lived through life without a diagnosis of Alzheimer's disease. I wanted to get a historical, was just a reflection on that. Completely different from the you cannot say it is Alzheimer's diagnosis of Alzheimer's disease. Days when you will present clinical MRI, so this and tau pathology, and these are the amyloid PET biomarkers of is a clinico-biological entity. Like saying stroke, right hemiplegia versus stroke, diffusion MRI is showing, MR angio is showing occlusion, then only you call it a stroke, right? Like that today dementia is also a biological entity. And it may not always have memory problems, they can be non-amnestic. So when patients come to us, they're coming either with progressive memory problems, progressive language problems, progressive visual. We heard a little bit, I'll spend time on 3 pathological entities, which Dr. Anantram very nicely showed. Now these 3 entities, let me go there. These are people who came with progressive memory loss. Only progressive memory loss, only hippocampal atrophy, but none of them have Alzheimer's disease pathology. And the three of them, so far they were only pathological diagnosis, but now with biomarkers we may be able to make these diagnoses. One is called late limbic predominant age-related TDP-43 encephalopathy. This has TDP in the medial temporal lobes, and that is why it has shrunk. You can see with age, late goes up. With age, amyloid and tau come down. So this occurs in the extremes of age. So if you see an 80-year-old man with memory loss, with hippocampal atrophy, you can't make definite diagnosis of Alzheimer's disease until you have biomarkers. And if they are negative, start thinking, is he accumulating TDP? 43. And then in such patients, of course, amyloid biomarkers will be negative. PART is the other entity. Elderly age, progressive memory loss, hippocampal atrophy, but accumulating neurofibrillary tangles. They could have normal cognition, they could have dementia. Sometimes the tangles can accumulate inside the hippocampal areas. They are called argyrophilic grain disease. So they are little inclusions in the hippocampal regions. Here it is not ApoE, it is not Alzheimer's gene, it is a MAPT gene that you typically see in frontotemporal dementia. It's not moving forward. Right. So here also you can see hippocampal atrophy. The importance is in these conditions, and third condition is hippocampal sclerosis. Here also you have TDP-43, but in addition you have sclerosis of the hippocampus. And this can also be a differential diagnosis. But in all these three conditions, it is the anterior hippocampus that is getting atrophied. And I was very happy to see Dr. Anantram show so beautifully the amygdala and anterior hippocampus atrophy versus the posterior hippocampal atrophy with then going towards the parietal lobes and precuneus. So the younger you are, the earlier you think of these diagnoses, the more you will think of them in the clinic, and who knows, maybe we develop biomarkers for these entities as well. So these are Alzheimer's disease mimics. And why are they important? Because they will be biomarker negative and they will not respond to anti-amyloid therapy. Go back to this one study that was done where they had a large number of patients with Alzheimer's disease. This is the NAC, National Alzheimer's Coordinating Center in America. Multiple centers come together and they had autopsies. So in the clinic, they had this diagnosis, and they had a diagnosis of Alzheimer's disease, but when they saw the pathology, about 30% had Lewy body dementia, 18% had some pathology, but it was insufficient. So that will map on to what Dr. Fahim said about little amyloid in the brain. Then many had vascular disease, frontotemporal dementia, and hippocampal sclerosis. So the list for AD mix is quite long, which you should be aware of. Right. So what we do in the clinic is, patient has some clinical symptoms. You want to see what is driving those clinical symptoms. What is the primary pathology? Is it Alzheimer's? So rather than saying, is this Alzheimer's disease, we should ask ourselves, is the Alzheimer's disease pathology driving the clinical symptoms? And there could be other pathologies. Will therapy then work in the presence of other co-pathologies? Say that you have Alzheimer's, all biomarkers are positive, you want to treat. Maybe there is vascular disease, maybe there is TDP, maybe they're not responding because of other co-pathologies. So it's all the more important to evaluate a patient comprehensively and not just focus on biomarkers and amnesia. Now very quickly I'll run through parietal syndromes. We've heard about them, all these posterior cerebral cortical atrophy type syndromes. And here it could be PCA, it could be corticobasal syndrome. In one there will be biomarker, Alzheimer's disease biomarker positive, but in the other you can see it could be positive in a corticobasal syndrome, but you could have a host of other pathologies. So in posterior parietal syndromes, biomarkers will help us guide whether there is AD pathology or not. So this is very quickly I will rush through. This is a frontal syndrome. Patient has inattention, socially inappropriate behavior, apathy, and reduced speech. Please start thinking, is this Alzheimer's disease? Is it FTD? And this patient had impaired attention, working memory, and impaired executive dysfunction. Now, obviously, we'll go to biomarkers. So this is where Dr. Fahim was talking about pre-test probability. Before you do a clinical test, before you do a biomarker test, you have to know what is the pre-test possibility. For instance, if the right hemiplegia and you pre-test possibility for amyloid is practically less than 15%, right? Except age, there is no risk factor that he should have amyloid. But if he has a progressive amnestic syndrome and there is no other pathology on MRI, the pre-test possibility will go above 30%. Then you do a biomarker. Think in this patient, what is the pre-test possibility of a dysexecutive syndrome having Alzheimer's disease pathology? It is more than 30%. So we can go ahead with the tests. And this patient indeed had amyloid positivity. Now this is what Dr. Fahim said. It has to be more than 90% sensitive and more than 90% specific to say it is due to Alzheimer's disease. So here amyloid is driving the clinical syndrome. So similarly, there's another lady who came with behavioral problems with memory loss. What is the pre-test possibility that she will have Alzheimer's disease biomarker positive? She had, recently we did a brain autopsy. This was just 3 days back, and Dr. Kaul, it was your student Vaishnavi. She made the diagnosis preclinically. We were surprised. This is the history. 61-year-old lady, some forgetfulness, difficulty in recognizing family members, naming difficulty, except for some motor perseverations. And her scan showed some frontotemporal atrophy. But she was so confident. She said, I think, she did say Alzheimer's disease is the first diagnosis, but second possibility, she said, I think this is a behavioral variant FTD. And I asked her why. She said, Madam, this lady was a very outgoing person, very, very stable, emotionally regulated person. She became emotionally dysregulated. She became very anxious. That for me, I felt that it was Alzheimer's. And then it was FTD. Then recently had a CPC and Dr. Anita Mahadevan cut the brain. This is not that patient's picture. We have not yet got the pictures. It showed TDP-43. So again, so now clinical examination has become even more important than before. So there are some differences between behavioral with AD and behavioral with FTD, and how do you differentiate between them. Similarly, you have a language disorder. It could be logopenic aphasia. It could be non-fluent aphasia. In logopenic aphasia, grammar will be fine, comprehension will be fine. It's problem with repeating. It's at arcuate fasciculus. Whereas in non-fluent aphasia, there will be grammatical errors. There will be phonological paraphasias. So even though they're speaking less and there's word finding difficulty, and there will be apraxia of speech in non-fluent aphasia of FTD. If you look at these 4 or 5 signs, then your pre-test possibility goes up. No. So in you don't have to talk to this patient. What is the diagnosis? It's very difficult. And then they forget. Lewy body dementia, don't the cholinesterase inhibitors show a dramatic response in the initial stages, and biomarkers are also very crucial, but there could be an overlap and they could have 2 pathologies. And now this is a patient with progressive memory loss, executive disease. This is amyloid PET. A group of them will have amyloid PET negative, but and vascular, clearly they will progress much faster. Then I'll go through the so-called reversible causes. There was clear anxiety, episodic fear, panic attacks, sleep disturbances, and NMDA was positive. So you can have a chronic presentation of autoimmune encephalitis, and that is something you should never ever miss. And then this patient really improved with immunomodulation. This patient was with apathy and memory loss. You really don't get textbook descriptions. Most of our patients are not reading the textbook. So this was memory loss, apathy, disorganized. Patient had cerebral amyloid angiopathy. Then never miss a structural disorder, CJD, carcinomatous meningitis, tumors, and then there is this patient that I've seen before, but this is from an article, dural AV fistula, some faint white matter hyperintensities. So in our overzealousness to do biomarkers now, we should never miss a subtle structural disorder. Therefore, to summarize, why is it important to diagnose AD mimics? Because a third of them are misdiagnosed and diagnosed late. We should have a high index of clinical suspicion. All the more reason to do a clinical, cognitive, imaging, laboratory, and genetic approach, and come back to clinical, cognitive, imaging, laboratory, genetic approach. And this is what we do in the OPD. Day in and day out. This is we call the patient back, look at things again to make a diagnosis. Biomarkers have really changed the way we diagnose. Follow-up is important. Evaluating trajectory is important. And AD mimics will obviously not. I still remember a stroke patient. No, I think it was a patient where they were doing organ donation. Dr. Kaul will correct me. And patient was actually, the social worker had come to talk to the family members for organ donation. Patient had phenobarbital poisoning and was sitting up the next day. And I can't forget how, we all quietly were feeling so embarrassed that we thought this patient was probably, brain dead. We'd not done the toxicology screen. So these are the kind of things that we do not want to happen when we're giving disease-modifying therapies. So there's no rush to give them, but there's an urgency to investigate them properly because patients are getting very anxious. So I think with this I will stop and can go for lunch maybe after this. Thank you.
Wonderful talk. From the other field with wisdom. There's so many.
Good afternoon all. Today's case is about 71-year-old gentleman who is resident of Khammam, retired botany lecturer by occupation, right-handed individual, no religious affiliation, informant himself and wife. They came with the chief complaints of forgetfulness since 1 year. Pre-morbid state. Patient lives in Khammam. He has 2 daughters who live in USA. He worked as botany lecturer till 2012 and retired. Post-retirement, he was active, used to wake up around 6 a.m. daily, finished his toileting, bathing, interacted with the neighbors, spent time with relatives' granddaughter who stay upstairs. He used to travel to nearby village on bike, which is 20 kilometers away from Khammam, looked after his farms, visited his mother and came back. He has habit of writing diary at night and goes to sleep at 10 p.m. History of presenting illness. He was apparently all right 1 year back. He had been to USA later last year to meet their daughter, where daughter noticed slight confusion and repetition while talking. He used to forget conversations and repeatedly ask the same questions. But as the month progressed, this difficulty worsened. After they returned to India, wife noticed that he was unable to recall names of his banks and PhonePe passwords. Hence, he stopped transactions through PhonePe. He currently pays cash at the shops and has no difficulty in paying the bills and collects the right change from them. No other difficulty in operating the phone. He swipes the screen to unlock it, able to use WhatsApp, sends messages to his colleagues. There is no history of asking for food again after eating, no history of misplacing things, no history of difficulty in remembering past events, no history of getting lost, and no navigational difficulty. There is no difficulty in writing, reading, word finding difficulty, no difficulty completing sentences while talking, and no history of irrelevant talk. He even attends relative ceremonies and interacts with almost all of them, but sometimes forgets relatives' names. He maintains self-hygiene and there is no history suggestive of frontal lobe dysfunction, no history of waxing and waning of symptoms. There is no history suggesting of extrapyramidal or pyramidal involvement. No history of sleep disturbances, violent dream enactment behavior, no headache, fever, weight loss, no loss of appetite, no seizures, no myoclonic jerks, no drug or toxin exposure. Present functional status, he is able to carry out all his activities of daily living on own, travel on own, except for difficulty recalling passwords, names, and mild repetition. Past history, he is not a known patient of diabetes, hypertension, tuberculosis, epilepsy. No significant past history. Personal history, he takes mixed diet, appetite, sleep, bowel bladder habits are regular, no ill habits. Family history is not significant. Summary, 71-year-old male with no prior comorbidities, presented with history of slowly progressive memory disturbances since 1 year, involving episodic memory loss and inattention, with no other domain involvement, no history of extrapyramidal, cerebellar, motor or sensory involvement. From this history, it is likely major cognitive impairment as his instrumental activities are affected because he is unable to use PhonePe currently. Likely isolated amnestic syndrome due to degenerative pathology, Alzheimer's disease. On examination, he is conscious, coherent, oriented to time, place, person. Vitals are normal. General examination is normal. Other examination is normal. CNS examination, higher motor functions, MoCA is 23/30. He lost the points in delayed recall, trial and clock drawing. Right-handedness, education, highest level is MSc Botany and PhD in plant pathology. By occupation, he is retired lecturer. Consciousness is alert. Attention, digit forward is 5, backward is 3. Vigilance, is no errors in vigilance. Serial 7 subtraction is also normal. Language, verbal fluency with P letter he could tell 12. Semantic fluency, total vegetables he mentioned were 12. Comprehension is good. Repetition, naming and word finding are normal. Reading is normal. Writing, he could write without any grammar mistakes. Memory, immediate recall, digit forward is 5. Recent memory, name, age, birth, present location, everything was normal. Remote memory and historic facts he was able to answer. New learning ability, 5 unrelated words. He took 3 attempts for registration and delayed recall was 0/5. It was not even improving with cues. Visual memory, 0/5. Constructional ability, he could copy the cube. Drawings to the command, this is the flower pot drawn by him and this is the image of house. Clock drawing, even after 2 attempts, he either kept the numbers outside the circle or forgot to keep the numbers and only kept the hands. Calculations normal. No apraxia. There was no right-left disorientation. Finger agnosia and Jessamine syndrome, no points suggestive of them. Visual agnosia is absent. Simultagnosia and there was no hemineglect. Cookie jar theft, he could interpret the complete image. There is no hemineglect, line bisection is also normal. Stereognosis is normal. Frontal lobe, motor and graphicuria both are normal. Abstract thinking, similarities, go, no go, everything he could do correctly. Trial making, trial A he could do properly, trial B he made few mistakes. Stroop test is normal and utilization behavior, environmental autonomy is absent. Speech was normal. Cranial nerves examination, motor system, sensory examination, cerebellum examination were normal. Gait is normal, there were no frontal release signs. Coming to the investigations, after routine blood test, everything CBP, RFT, LDL, everything was normal. Vitamin B12 was 318 and TSH is normal. CT brain showed symmetric frontoparietal atrophy. PET-CT brain showed reduced FDG uptake noted in bilateral prefrontal, frontal, cingulate, bilateral basal ganglia and temporal lobes. This is the PET-CT image. Finally, we thought it is cognitive impairment secondary to AD pathology. Now, is he too late to receive the newer anti-amyloid therapy? Should we refer him for further investigations or?
Can we have the discussion after the topics because of the therapy? Yeah, therefore we will we'll ask the faculty what should we do.
Okay.
Yeah. Thank you. The next topic is about therapy, and I request Suvarna Madam to present.
Thanks. So, I think when we have friends like neurologists in KIMS, one doesn't need enemies. I have a disclaimer, I have not treated anybody with anti-amyloid therapy. So I think that there are neurologists in the country who have started treating. And what I will do, the topic that has been given to me is checklist for anti-amyloid therapy. So this has made us work very hard. And it's been a learning process. I think we're all in this together. We're in very exciting times. I remember the first thrombolysis that we gave in KIMS. We were about 7 neurologists. And the 7th patient bled. And I was in charge of that stroke patient. And then Dr. Kaul said, of course, 1 in 7 will bleed. So that means we're doing something right. So now we've come back to that now. And you can see how things have changed in stroke. If you remember the original recommendations, there was a checklist for stroke as well, and you can see how it has changed. So I think we are on the threshold of something very similar. And what I am going to do is completely based on existing world literature, clinical trials, and our efforts within what we have formed a Cognitive Neurology Association to develop some guidelines. What typically happens is that in places where the drugs are being given, there have been longitudinal studies of people with Alzheimer's disease. They have tracked them over 15 years. They have seen how that amyloid has built up in the brain. And then they located clinical trials in those populations. And then they saw how they changed. So the neurologists in the rest of especially in the Western world, understand the neurobiology of Alzheimer's disease. They understand how the trials were done. They were part of the clinical trials. They were trained with the clinical trials, and then they gave the drug. On the other hand, what has happened in countries like India is with some initial kind of preparation, the drugs have received approval. So it's a huge heft for all of us to really understand how to give these drugs and select the right patient. And the first step is to have a checklist. So what I'll do is start with the clinical trials and see how patients were selected in the clinical trials. Why were those inclusion-exclusion criteria so important? So that we don't just tick the box, but understand why that criteria came to be. Why was this particular criteria there? That's based on some 20, 30 years of research. So if we understand why that criteria is there, then we can treat the patients better. So I'll first talk about the criteria and clinical trials. But indications in real world, in the clinic, go beyond clinical trial inclusion-exclusion criteria because our patients, for trials, patients are included very strict criteria. Now our patients don't follow those criteria. We have all kinds of exceptions. So then what are done is appropriate use recommendations are given. Thanks to Dr. Kaul. We have Praveen. We have compiled a checklist and we'll present little bits of that checklist. But then move beyond a checklist to a clinical approach. Again, we come back. The checklist, we've been applying the checklist. There is retrospective application of the checklist and recommendations. And then you start seeing, there the excitement starts. Dementia patients. And then some cases to illustrate this. Trial, which demonstrated, and the Trailblazer ALS2 trial, where the drug donanemab was used and again demonstrated almost similar efficacy. Now, these are monoclonal antibodies that bind with different, you'll again hear from Dr. Ratanu, but bind with different forms of the amyloid. And then in that binding, they remove it from the brain, and then the levels of amyloid.
Because if you can preserve the cognition, that level of cognition for the longer duration, that is what this drug can do, and that is also will be beneficial for the patient and for the family. So there are several biomarkers available. PET is now available only in limited setting, and also PET, amyloid PET and tau PET is not introduced in the country, but the drug has already been introduced. So we have the CSF biomarkers and the plasma-based biomarkers. So that has already been discussed by Dr. Fahim. And in JAK, this is the famous, the hypothetical graph. It is now called the JAK graph, where he showed that probably the amyloid starts 10 years or 20 years before your symptom onset. And then come the others, tau, and then the other inflammation and neurodegeneration. Then patient becomes symptomatic after 10 years of this. So if we want to target this amyloid or any drug with the disease, we have to give them very early in the disease course. And these are all biomarkers approved by the US FDA. 2 companies. Now both these tests are available. And you have to make a diagnosis clearly, clinically, exclude other conditions, and biologically you have to prove that the disease is because of the Alzheimer's pathology in the brain. Then only you can select, you can go for the therapy, and of course you have to exclude many things Dr. Subban has already told. The 2 drugs which are available now in India also, one is the lecanemab. The study was published in New England Journal of Medicine. It is called the Clarity AD study. And the donanemab, which was a Trailblazer 2 study. And their targets are totally different. One is targeting, the lecanemab is targeting the protofibrils, and whereas the donanemab is targeting the plaque. So targets are different, and 2 drugs have somewhat different dosing schedule, but almost a similar level of side effects profile. So this is the Leqembi or the lecanemab, which targets the protofibril, and they bind to that. These are the IgG antibodies, monoclonal antibodies developed to target, and they bind to these protofibrils, and in effect the body removes these protofibrils from the system so that the plaques are not going to develop. This is what the primary idea of the drug is. So the Clarity AD included almost 1,800 subjects with MCI and mild AD, MCI due to AD and mild AD, randomized to lecanemab 10 milligram per kg biweekly. So every month you have to take, patient needs to take 2 infusions, and it was a double-blind placebo control, so placebo arm was also there. Treatment was given for 18 months. But after the therapy, as the patient and the drug showed some improvement, so there was an open label phase also. Whereas the Trailblazer 2, it included the same type of patients, although they are somewhat different. But no Indian patients are included in both of these studies. Some of the Asians, like the Japanese or the Koreans, are included, but Indians are not there. That's why we are very, very much apprehensive how the Indian patients will behave with this drug. So in the Trailblazer 2, there are 2, although the early AD and the MCI are there, CDR 0.5 and 1, but they divided in group into 2 groups, low, medium tau and the high tau. Tau, when the tau comes, then the disease is probably a somewhat advanced. So if there is high level of tau with the tau imaging they detected, so they will, how they do versus those who are having a low tau level in their brain were also compared in this study. So almost 1,736 patients, similar like that of the Clarity AD, and 1:1 infusion, patient and of course, drug and the placebo was used every 4 weeks. The therapy is for every month infusion. Again, 18 months therapy, and after 76 weeks, the trial ended, and there was, of course, a long-term extension study following that. So what happened? In both the drugs, they showed a clear benefit of removal of amyloid from the brain. So you can see from these graphs that those who received placebo, there was almost no change in the amyloid level in the brain through amyloid imaging. Whereas in those who received lecanemab and also in donanemab group, low tau or high medium tau, both showed a clear benefit in the removal of the amyloid from the system. But is it important to the patient? No. Patients or the family members want that there is some clinical improvement. So this was assessed through the use of CDR sum of box scores. In the lecanemab, initially after 18 months of therapy, they showed a clear benefit, statistically significant benefit in the lecanemab group. And also this is the ideal. The activities of daily living also remain is better in patients in those received lecanemab than the placebo. Whereas in donanemab, it was assessed in a composite score, also showed after 76 weeks, there was a significant benefit. Significant benefit means there was statistically significant, but for a particular patient, there might be a not that significant one. Again, the CDR sum of box showed us 36% slowing of the low medium tau group. The low medium tau group, they did better with the donanemab as compared to those who are having high tau group. This is a sub-study for the CDR sum of box score in lecanemab group. Lecanemab was continued after the completion of the study for those who open label study, but there was no comparator group. So what they did was they used the ADNI and the biofinder, the cohort, where we know that the natural process of the disease is to progress further, deteriorate further as the time progresses. So they took that group as a comparator and they continued the lecanemab for a longer duration. And this also showed a significant difference at the end of 42 to 48, almost a 4 years study. So this long-term extension study also showed that the lecanemab was doing good to the patients clinically as well as by removing the biomarkers and changing in the biomarkers. Donanemab long-term study, extension study also showed a similar benefit over the time. As the time progresses, there was some wide difference between the patient treated and those patients did not receive any treatment. But the problem arises was that during the study period, although they did well with the drug, they also developed some side effects. These are amyloid-related imaging abnormalities. Because the amyloid, if they're in the blood vessel, there will be edema, there will be fluid will come out from the blood vessels and produce edema, and also there might be hemorrhage. And as already Dr. Subban has told that there are some risk factor for having this, so they tried to exclude those. But still, this area was not prevented. This is a machine learning models of evaluating area risk factors. So what are the risk factors? Those who are having ApoE genotype, ApoE4E4 homozygosity, they have higher risk. So also the microhemorrhages, more than 4 microhemorrhages and the 1 superficial siderosis, but also other factors like the hypertension uncontrolled and the amyloid PET burden if the amyloid is too much in the brain, they have high likelihood to have the ARIA. So, in effect, the ApoE4 genotype, number of baseline microhemorrhages, the presence of superficial siderosis are the most consistently found to increase the risk of ARIA. For ARIA age, the same, almost same. So, what are the ARIAs? ARIAs are the edema in the brain that were not there before starting the therapy. So, before you infuse, you have an MRI which showed that if there is no brain edema in the particularly the white matter areas and the gray matter junction. But if you are having new development after infusion, these are ARIA E. So these are inflammation, if the edema, if you can pick up in the good MRI. Then moderate MRI is slight more swelling. Maybe there is some quantification of that. And the severe area is bilateral, almost involving the more than one lobe. So these are ARIA E, edema. And hemorrhage also, there is some more than, if you have excluded the microhemorrhages, appearance of new microhemorrhages or macrohemorrhages in the brain, these are suggestive of ARIA age. So in the Trailblazer 2 study, there was a 24% ARIA E and 31% of them developed ARIA H. These are numbers, but they are not clinically significant. Most of them are asymptomatic or they are having mild symptomatic. But 3 participants had serious ARIA events resulting in death. So this can also happen. So one not told about the experience of giving thrombolysis. If a patient of Alzheimer's disease, if you treat him with this anti-amyloid therapy and if he dies sometime, then probably in your clinical practice you will be in a very difficult situation to explain. So before giving, we exclude those who are having the increased risk factor. Whereas in Clarity AD, the ARIA E and H was significantly lower as compared to the donanemab group, this at least Trailblazer 2 study. It was only 12.6% ARIA E and 16.9% in ARIA H. Then this donanemab group, they did another study because their infusion pattern was somewhat different. So they manipulated this and they did another study called the Trailblazer ALJ6, where they showed that there is a significant reduction in the adverse event of ARIA E as well as ARIA H. What they did was that in the initial infusion, they are giving 300 milligram 2 infusion, that means 700 milligram in the first month, 700 milligram in the second month, then the third month, and the fourth month onward, they used to give the full dose of 1400 milligram for the rest of the period of 18 months. Now they have gradually escalated the dose by giving 1 infusion in the first month, 2 injections or 2 bottles, rather 700 milligram in the second month, and 1050 milligram in the third month, and fourth month onwards the 1400 milligram injection for the total duration of 18 months. So by this way, they tried to reduce the risk of ARIA E and ARIA H. Remind you that most of this ARIA develops during the initial period of the infusion. So that's why if you have to monitor the patient with serial MRI, you have to monitor it for the very first few months or for the 7th infusion, up till the 7th infusion. So by this way, they have reduced the risk of ARIA E and ARIA H and now they are recommending this type of dosing schedule. So what are the ARIA-E and ARIA-H? How will you manage them? Majority of them are asymptomatic. If it is asymptomatic ARIA-E or ARIA-H, you can continue the infusion, or you may even, if it is moderate, you can hold for some time, give the time to resolve the ARIA-E, and then, of course, take everything into your confidence by taking the patient and the relatives. Then you can even restart the therapy. But if the patient is symptomatic, and even after clinically severe, you might need to hospitalize the patient, give them the IV steroid, or if it is possible, if there is a reduction in the ARIA-E, then you can discuss this and with the patient party, and also you can restart the therapy. Otherwise, you might have to stop if there is no reduction or the party is not willing to. Now, another drug which is there in the pipeline is the totinemab. This is a monoclonal antibody developed by the Ross people. It is almost like that of the gantenerumab, but it is engineered. They are claiming that this drug removes amyloid from the deeper part of the sulci and gyri, and they have the reduced chance of ARIA, as the phase 3 trial showed that this showed only 1% ARIA-E risk factor. So this is not yet approved or by the US FDA, but this is one more drug which is in the pipeline. So I will stop here. If there is any question, please. Sir.
Definitely the checklist was exhaustive, and therapy is also doesn't seem to be quite straightforward, and problems are there.
Yes, and also there is a fight between the two companies. One is claiming donanemab that it is the 18 months therapy, that is there is a finite duration of therapy. So after 18 months you can stop the therapy, because they remove the amyloid so much so that if at all the amyloid again get accumulated, it will take 10 years to become almost the us becoming symptomatic level. Whereas this lecanemab, they are not a finite therapy. It has to be given twice a month infusion for an indefinite period. There are arguments in favor and arguments against. So this is also there. So choosing one drug is also a very tough question.
The therapy actually shows that the amyloid has resolved completely. Okay, there are a lot of studies which are showing that some patients have the amyloid has completely dissolved and then they became completely negative. Clinical improvement is too early for us to say, or it will take another 10 years for us to actually know whether this is beneficial or not? Or is there a clear clinical benefit which is observable?
As of now, the benefit, that means the cognition improves. The CDS improves. This has not been claimed by any of this drug. They are telling that this will remain in the same level. There will be a CDS sum of box gets improved. Means that the quality of life or maybe the patient's performance in the society will improve somewhat. If you are removing this in an early stage, you can keep the patient in the same stage for a longer duration. Maybe for the rest of his life. We don't know. Very difficult to say at the moment.
We also have Dr. Athar from the Lekembi. Would you like to throw some more information?
So, disclaimer, I am an ISAI employee. So, yeah. So basically we had this AAIC 2026 paper which was published, and we had the phase 4 studies for lecanemab for Japan. So as you know, it was earlier launched in other countries. So 59 countries it has already been launched. India, it was launched 2 weeks back, and we had the safety profile for the drug. So we had the data for ARIA-E and ARIA-H published for the phase 4 studies which were done in Japan. And the symptomatic ARIA-E cases was